wonder that this child with disorder or falling in the category of autistic spectrum disorder will not have a proper social interaction even with the parent, and that's the first concern which the mother will at the age of even 6 months itself. At what age usually the parental concern starts? I will say usually the parental concern starts between the 18 to 24 months. But what can be start when can it start is even at 6 months you can identify with the soft signs the autistic spectrum disorder. So what is autism in simple language? A simple language where usually our teachers used to teach us that the child is living in his own world. His own world. What is his own world? The child is not trying to connect with somebody. The child is not trying to interact with somebody. The child is not trying to engage with others meaningfully since others. These three are the important things: connection, interaction, and engagement. How do you connect? When you have a good proper eye contact and when you respond to somebody. That is the connection. Interact, two-way interaction. What is very important for interaction? A language is very important. A communication is very important. Engagement, back and forth communication. So these three things are falling. So there are various myths which I would try to demystify. So it is not due to a vaccine, which has been, the myth has been demystified. It is not due to excess screening time, because most parents who come after this pandemic, they say that this problem has come only because of the pandemic, where the child was not given more screen time. I will say the screen time is not the cause for the problem. Since the child is predisposed for autism, the screen time has aggravated the problem. Probably the child must have fallen in the category of 10 to 30%, sorry, 20 to 30%, the excessive screen time. Because of excessive screen time, he is not able to interact with many people. So since he is not able to interact with many people, the symptoms, he has traveled above in the spectrum from 30% to 60%. So that is not because of excessive screen time, but it can be aggravated by screen time. It is not due to lockdown. This is also the many parents come and say, because of the lockdown only this has happened. I am not able to take my child to anywhere. I am not able to take my child to my sister's house or my friend's house. I will ask them, how many days in a month will you take your child to your sister's house if it is not a lockdown? Probably once in a month, that to 2 hours per month. So in that 2 hours only, is the child going to learn the language and communication? No, it is not like that. So I will say it is not because of the lockdown. Probably the lockdown has simply aggravated. So it is not a problem of a speech or a language. There are a multiple of problems, and speech and language is one of the problem of an autism. It is not because of father spoke late. This is also one another. Immediately the grandmother will say, the problem is not pesறது. The problem is interaction with everyone. Not because we use two languages at home. There are cases where both the parents' family use different languages, and that also they bring it to the notice when we talk about this. Not due to lack of exposure, because we live in an apartment. So these are the usual things. Whenever we ask the parent for a referral, they come out with all these points so that they wanted to deny the diagnosis and avoid the referral. So you should try to say that all these are not the pointers. It starts in utero and it is lifelong problem. That is very, very important. But there are few cases who can come out of that. So what has changed in the recent years? So what has correct? So they initially thought that it is a medical disease, and they thought that, oh yeah, there should be some cure for that. Now they don't equate autism to a medical disease, but a deviation in the development. And I will always say, parent kadesiya kekra ore kelvi idu gunapadthiralama. I will say idu noi kedaiyadu idu gunapadthradhukku. It's a developmental or a deviation. So I should always find out the methods to improve his development. So it is always improving the development and not a disease and not a cure for the disease. The focus has shifted from disease to disability. It is a disability and not a disease. You should also try to teach your parents or talk to the parents that this is not a disease. This is a developmental deviation or a developmental delay. And now I am trying to improve your development. Moved from a medical model to a social model. Previously, it was autism. Oh, we have to do all these medical management and those things. Now it is not. We have to integrate this child into a society. Autism is actually a variant of normal human development and human diversity. And always you should try to understand what this human development and human diversity and those. So coming to what goes wrong in the normal social communication, you should always know that the problem is not language, as I already told you. The normal thing is the normal social interaction. Only when you socially interact with few people, you understand their behavior. So when you go to Germany, you stay in a room for 1 month, you don't talk to any people, you don't know how to behave. On the contrary, you go out everywhere, talk to few people in the month, and then you understand their language, you understand their behavior. The same is the problem with the child with autism features. So they don't even socially interact with the parent. The parent is at home, the grandparents are there, the elder sister or elder brother is there, but this child doesn't socially interact with them. So they don't know what the other parents behave, other people, how they behave. They don't know how they behave. They don't learn non-verbal communication from them. If there is no non-verbal communication, then further they don't learn the verbal communication also, and further all those skills, starting from the basic thing is the social skills are lacking. When the social skills are lacking, they are not able to learn the behaviorals. When the behaviors are not learned, the verbal communication and the non-verbal communication skills are not learned, language skills are not learned, fine motor skills are not learned, gross motor skills are not appropriate, academic skills are not there, play skills are not there. So every skill the child is lacking in the future. So early signs are related to the absence or paucity of social engagement between the child and the caregiver, lack of engaging eye contact, and meaningful social smile should alert the discerning parent and the pediatrician. Since he does not know how to connect or interact, he does not learn how humans behave. That is the very, very important thing. How to behave with other people, he does not know. He doesn't know how to smile, stare, or make faces at each other. So social behavior is not learned. How to brush the teeth, how to comb hair, wear the clothes, eat from the plate. All these social behaviors are not learned. Non-verbal behavior, even at the 10 months or 12 months, when a child can even say, where is Akka? The child will say, point pannu. So that is a non-verbal behavior. I will ask the parent. So what referral parent, I will ask them. So okay, fine. Whether the child point it, whether the child will point the finger and show there is my sister. No, lack of they learn the meaning of signals given to them and also to give signal to them. So the two-way non-verbal communication is absent. Learn the meaning of oral sounds and also to use those sounds. So this is very important. Receptive language, expressive language. Receptive language is something you receive from others and understand what they talk. Expressive, you give the answer. A child with probably a speech delay or a pure speech delay or a late talker will be able to understand. In Appa 3 vayasula pesnaru, Tata 4 vayasula pesnaru, all these things are late talkers. They are very good at their social behaviors. They are very good in the receptive language. What I will ask them, well, they go and give that. Yes, they give. So then their receptive language is very good. Only their expressive language was not adequate. So that means that their verbal communication is also very, very bad. So what they do, when they are not able to do all these things, what they do, they try to focus on objects because they don't know to interact with humans. The humans, since they are not able to interact with humans, they try to focus on these objects. So what they do, they understand to try to pattern copying. So this is the classic thing, sir. My child will, he will say Baba Black Sheep, sir. He will say Kandasasti Kavasam. He can read A, B, C, D from Iset, apple to zebra, everything he will do, sir. But Idli Vedama, yes or no will not be there. Pal Vedama, what do you want to eat? He will not say the answer. So only he know to copy. He will learn to copy. All these YouTubes are there to help you to copy. But he will not say even the basic answer that yes or no, either verbally or non-verbally. And he becomes rigid. So this is the thing which is happening in autism. So the point to be understood is, since the child is not socially interacting, he is not at all learning anything from others. That is the basic thing. That one of the thing is the language and the communication skills. All other things follow in the sequence. So the earliest features are the absence of normal behavior rather than the presence of abnormal ones. So you should always think that the absence of the normal behavior is there. So this is just to browse. So this is the core features. That is, impaired communication, impaired social communication. So social interaction is not there. Since there is no social communication, the impaired communication, he will not be able to interact or communicate with the other people. So what if since he is not able to communicate with other people, he has a restricted interest only with the toys, and he doesn't have to interact with the other people. So these are the problem areas, as I already told you. The social interaction problem, language communication problem. Then comes the repetitive behavior. Other issues are behavioral issues, sensory problem, emotional skills will be there. I will go one by one. So social interaction, the problem with the social interaction, how this will lead on to lack of sharing the interest. He will not share the interest. If he is having a birthday, he will go to the school, but he will not give a chocolate to anyone. If he gets a chocolate from other one, he will not be able to wish a birthday to them. Lack of response to contextual cues. How the other child gives some cues and all, he will not be able to say. Lack of response to name. He will not respond to his name. Lack of showing, lack of pointing. Use a other person's hand as a tool. That everybody must have heard in your private practice. Always he will take the father's hand to point to somebody, and he will not use his hand. Use a person's hand as a tool. So this is the social interaction. Delayed use of facial expressions, body language, and gestures. No facial expressions at all. Different facial expressions will not be there. So this is a good picture to show how there will be a good eye contact. This is a poor eye contact with the mother. So joint attention. This is very, very important. How a child learn from the environment. When you show somebody something, for example, if there is a cow in the street, the mother will show, okay, fine, there is a cow in the street. What the child immediately do will, the child will look in the eyes of the mother. Then the child will look into the hand of the mother where the finger is pointing. Then the child will go see the cow. So what happens is the cow's image will be captured. The sound, the mother which, oh, cow, 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 she will shout. Then the word will be captured. Both will go to the brain. There will be a sensory processing, and there will be a sensory integration between the visual image and the auditory image. So this will be the base for learning. So this is called as joint attention. What is joint attention? Jointly, the child and the mother is looking at the object, and the child is trying to learn. This is importantly or significantly absent in children with autism spectrum disorder. Usually this starts at 9 months of age and well established by 18 months of age. If the joint attention is not there, the child will not learn. So this is joint attention. There is a fish there. The child will first look into the eyes of the mother, then it will look in the fish. So, and both will start looking at the fish. So this is called joint attention. Lack of interest in peekaboo games. So the child will not be enjoying the peekaboo games like this. So social interaction, as I already told you, giving and receiving compliments, showing concern for the other. These are classical mothers have told. Sir, I must have cut my finger with a knife. The elder child immediately brings some water, everything, ice and everything. But this child will be laughing at me, sir. All these are classical things which this autism spectrum children will be having. So the facial expression, this man will be a good example for facial expression, but our poor child with autism spectrum don't lack this poor facial expression, poor response to the caregiver pointing out something or absence of pointing out. So he will also not point, and he will not also look at the area where the parent is pointing. So these are all good signs of pointing and looking at the area where the child is pointing. Language communication, as I already told you, there are two parts of the language. One is the expressive language, the other is the receptive language. And these are this ready reckoner which anybody will have in their table or any book will give this. What is the receptive area? Receptive means understanding area. Expressive means giving out area. So understanding the child, what the child will understand follows a verbal command at 12 months. First word will come at 12 months. So you should understand this. One command, kudu, va, po, nil, come here, go there. Adalla one word command which the child will be able to follow. First word, papa, tata, mama, all these will start at 12 months. So this I am not going to go in detail because everybody, but this one everybody should understand. In the area of receptive language, at 12 months, the child will be able to follow one action command. One action command is come, go, give, stand, sit, everything. The child will have one meaningful word, papa, tata, mama, kaka, whatever may be. 18 months, the child will be able to follow two action commands. Two action commands means give this to father. The child should go there and give it. So go there, give it. So two action commands, two meaningful words at 18 months. So sentence of two meaningful words. Amma pal. So like that, the child should talk at 18 months. 24 months, 3 action commands. Go to the room, put this there. So the child should go to the room which the mother is, find the room, go to the room and then put it there or come back again. So this is the 3 action commands. 24 months, say a sentence of 3 meaningful words. Amma, Pal, Veno. So this is the 3 meaningful words. So this everybody can have a rough estimate of whether the child's language development is good or not. So this is very important sign. The child may hear the sound on the TV or the doorbell, but may fail to respond to her own name. So these are classical, the parents will say. Because I see about 2 or 3 autism cases per day. These are the classical symptoms these parents come and say. Sir, chocolate is on odi vandruvam. TV parents on odi vandruvam. But tera kutta mattu odi varamatan, sir. So this is the classical thing. So that's the early warning signs, lack of alternating back and forth babbling. So this at the age of 6 months itself. Decreased use of pre-speech or gestures. So scripted speech will be there. The same thing. Baba, black sheep, abdiye solitaire ba. Echo lali. What do you want? Juice? Again, also he will say juice. Enna sapte. All these things will be there because he doesn't know how to answer that. So there will be there. Pop-up words will be there. So the same pop-up word he will use for a few days. Chittappa, chittappa, chittappa. He will say, what is that? Who told that Sittappa? Sir, our Sittappa vandirundharu appo avara paatha naanga Sittappa nu solli kodutho. He is still saying that word every day, Sittappa, Sittappa, Sittappa. So this will come out for a few days and then that will go away. So emotional regulation. What are the emotional regulation? Distress over the removing objects. You want every object to be at the same place. Difficult calming when distressed. Very, very difficult to calm these children when they get distressed. Abrupt shifts in emotional states and unresponsive to interactions. All these are emotional. Repetitive movements with objects. So all these are there. Repetitive movements or posturing of the body, like flapping pandrathu, toe walking pandrathu. All are these repetitive movements or motor mannerism. Lack of playing with a variety of toys. Always he will use the car. Car kadachiduna wheel போட்டு கவுத்தி விட்டுட்டு இருப்பான் இல்ல காலை வரிசையா வச்சு அடுக்கி வச்சிட்டு இருப்பான். He doesn't know the meaningful way to play with a toy. Excessive interest in particular toy. Using objects in unusual ways and uncommon attachment to objects. Unusual way na every car you should use it in a good way, but he will always put the car in the reverse way and try to rotate the wheel. Always insisting on the sameness. The hand flapping. The lining up of the toys. Varisiya car gada challengeri, toy gada challengeri. The child will try to line up. The toe walking, sensory and feeding challenges. Lot. I'm not going to go into that. The child, if you ask the mother, cooker sound, mixie sound, yes, he will be very even hypersensitive to daily kekra cooker sound na ana kada potikuva. Enge ponalu or bright light pata pidikadu, mallukkulla pona pidikadu. Because skin sensory stimuli will skin sensory. There are few children, patient kids first because they have this nasal sensory problem. So on the sensory issues children, nasal everything. Even in note they will start writing the pattern. So there will be a food acceptance or food rejection based on the food checker. So it will be very difficult for you to feed the autism children. So this is the extreme difficulty to haircut. So there will be hypersensitive to stimuli, self-biting with no apparent pain. So they are very sensitive to the light stimuli also. Play skills, preoccupied with one part of the body, always rotating the wheel or lying down on the floor and rotating and seeing the car, how the car moves. Lack of pretend and imaginative play. This is the pretend play. How to play with the kitchen set. How to play with that. This kids doesn't know how to do this pretend play and the imaginative play. Otherwise, they do this always the solo play and they will not involve themselves in group activities. So always the play will be there. So this child can be equated to an odd man in a wedding hall. So this person will go to the wedding hall. When somebody says hello, he will not respond. Somebody gives eye contact, he will not give an eye contact. He will not say, he will not smile when somebody smiles. He will not ask somebody what is your name. He will not say. He will not bring any gifts to the wedding hall. He will just go out, walk and come out. So this is the odd man. Comorbidities will definitely be part of there. All these are comorbidities. There are many cases where autism spectrum has been branded as hyperactivity or ADHD. ADHD is only it is only part of the problem. It is not the problem. So all these are part of the problem. Language impairment, anxiety, all these are part of the problem of the thing. And highlighting is ADHD. 13 to 50% will have ADHD. Intellectual disability will be in 30 to 50%. Sleep issues and seizures are there. So final 2 slides. And the intervention and the diagnostic part will be dealt by the next two speakers. What will a pediatrician do? Suspect clinically, advise the parents about the basic intervention and refer appropriately. So my few slides have shown that it is not the language which is the problem, and the other part of the problem which should alert you and refer you to this to the next nearby. Suspect clinically when the child cannot interact, do the social activities, lack meaningful and purposeful verbal and non-verbal communication. Meaningful, purposeful, the verbal and non-verbal communication is drawn towards objects and prefers objects to humans. Objects, he may show actions or words, but they are largely repetitive, meaningless, and patterned. You should always suspect. Counsel the parents on the screen time. Improve the direct interaction with the caregiver. First, to focus on improving the interaction. First is the interaction. Then the non-verbal communication and verbal. Neriya parents nera reverse la பண்ணுவாங்க. பேசல அப்படினோட ஸ்பீச் தெரபில போய் ஒரு 6 months வேஸ்ட் பண்ணிடுவாங்க. So that is the last one to be done for these children. And success will always depend upon starting age of therapy. Very, very important. I will say all these 4S to the parent. 1.5 வயசுல therapy start பண்றதுக்கும் 4 yearsல therapy start பண்றதுக்கும் there is a major problem. Severity of the problem, 20% severity, 40% severity, there are problem. Skill of the therapist, whether your therapist is very skilled in handling these children with autism spectrum. Sincerity of the parent க்கு இருக்கிற நம்பிக்கை, that is very, very important. நம்ம childரையும் improve பண்ணி கொண்டு வர முடியும். That is very, very important. All these successful peoples in the world, they were in the autistic spectrum, and I am also going to show the last patient, and this is the first child who has been diagnosed with autism spectrum. This is the childhood photo, and this is the adolescent photo. This is the first child who was diagnosed to be autistic. You won't believe, even the person is still alive. Donald Great triplet. He is the person now born in 1983, and now he is 89 years old, and he is still alive. You won't believe that. And I should always also mention, this is my case, which I have seen in 2018. So this is the child in 10/12/2000. This is from my old records. 10/12/2000, I have seen the child 2 years 12 months. The child at 1 year shifted to Malaysia, born in India, shifted to Malaysia, still living in Malaysia. I saw the child in the age of 2 years 2 months. See, 1 year 8 months, speech delayed, put in play school, back to India at 2 years, concern, decreased sitting tolerance, speech and language not appropriate for age, not responding to name call always, not requesting for things, on interrogation, not following instruction, decreased eye contact, preoccupied with spinning objects, still to follow. So started therapy at 2 years 4 months. He's done this therapy 3 years 3 months. Barring this few months for COVID interruption, continuous therapy in the same center. Now, I have seen the child 4 days ago. Now he is 5 years and 6 months old. See, all those language perfect, communication two-way, verbal, non-verbal, hyperactivity reduced, inattention is not there, behavioral issues are not there. You will be stunned to see this child. So, see the ability, not the label. So, see the ability and try to improve them and make these children come out of this label. So, that is the way. And I thank all the team of Child Development Center who have been working behind me to improve these children with autism spectrum disorder. Thank you. Thank you very much for this opportunity.
Soms, that was an excellent presentation. So
Thank
much
you, madam.
passion is seen through your presentation, and we are happy that you are, you're seeing those patients. Lot of anecdotes you have shared with us, and we know that, as you said, earlier the therapy started. The earlier, first of all, identification. That's a very big, very big thing, which I feel there's a very big gap between picking up the problem and when the problem starts. So I think the next, now Sudhakar is going to tell us, I think we'll take the questions at the end of the 3 sessions, because I think they're all autism related.
Yeah.
Yeah. So Sudhakar is a student of KMC, but he became, I think, again, Development Pediatrics brought us together. He's another passionate developmental pediatrician having his own center, doing very well. And also, he's now in charge of the Child Development Clinic at ICH. And he also finished his PGDDN course. And Sudhakar, it is over to you. You're going to talk about a very important aspect of picking up autism as early as possible. So over to you, Sudhakar. Sudhakar,
now only I'm able to unmute, madam. Good evening to every one of you. I thank the organizer for giving me an opportunity to talk in front of the 1 minute.
Yeah, it's visible, sir. It's visible. Yeah.
No, it's not moving. That is it. I have some technical problem.
You come out of full screen mode, then sometimes it may move. Just escape from full screen mode and see whether it is.
Yes, madam. I couldn't see. Yeah. Madam, please. I think.
Yeah, it's moving, Sudhakar, now.
No, madam. It's randomly moving. I'm not doing anything actually.
Okay, you want to make it all right? Shall we?
Yeah, better. Next speaker, better.
Okay.
Dr. Lal.
Dr.
Yes,
Lal is here?
Yes, sir. Yeah, I'm ready.
We can't see you though, Lal.
I think, yeah.
Yeah.
Am I visible now?
I think I'm seeing Lal probably for the first time.
Yeah.
Dr. Lal, we had asked you for a short CV, and I think your short CV itself is a very impressive one. So here you are the director of the CDC in Savita Medical College and an MD of Vistara CDC Group. He's a founder of MD. I almost thought that he's, some a businessman or something. So he's an MD of Jinvi Tech Private Limited and Adiona Company. What are these things? All different special needs education support. And he is a course coordinator for IAP Fellowship in Development Pediatrics and for MSc Child Development and Interventions in Savita Medical College. He's won the prestigious C.V. Raman Award for Excellence in Medical Research, and he's authored 4 books, and he's done medical research on disability, and he's also finished his PGDDN, and he is a fellow of the Society of Academic and Scientific Society Medical Research. He's a member of IAP Neurodevelopmental Chapter, I think, member Society for Development and Behavioral Pediatrics USA, Research and Intellectual Property, Savita University, trainer of IMNCI, and he is an AHA certified PAL. So that's Lal supposedly in short for you. It's over to you, and we are looking forward to your talk.
Is my screen visible now?
It's visible, though not at the first slide. Yeah.
Now?
Done. Yeah.
Okay.
Yeah, just full screen. There's a problem, then we'll continue with this.
No, there's no problem.
Perfect.
So today's topic is about autism evaluation and interventions in resource constraint settings. So I am also constrained to keep it very simple as far as possible, because when we go into investigations, I would like to put out a caveat that there is no investigation which is diagnostic of autism. So when the topic is like evaluation, investigations, etc., please do not think that way. One more thing I want to bring the attention of this August audience is that The autism is a neurodevelopmental disorder, as rightly pointed out by Dr. Soames. When you say neurodevelopmental disorder, what it means is that the brain is not attained those skills, and therefore the child is having a developmental delay. This is totally different from a child, an older child who is having, who probably got a stroke and now recovering. There, in this case, you are doing what is called rehabilitation. Whereas in an autistic child or in any neurodevelopmental disorder for that matter, you are dealing with a brain that is not got trained at all. And therefore, I believe that very soon this particular terminology called rehabilitation will soon be replaced by what is called habilitation. In fact, that is what is required for these children. It is just habilitation. And I'm sure IAP will soon come out with guidelines for that. Now, having said that, what is this habilitation approach that we can have to simplify the problems that we face in the busy OPD? See, all you have to do is when the parent comes, you have to give your lending ears. You have to identify their concerns. You have to acknowledge, yes, there is a problem which these people are trying to convey, listen to them, and then act. So how do you act? All you have to do is, after taking up a detailed developmental history, you have to go for what is called as a general developmental assessment. I'm not talking about a diagnostic assessment. I'm talking about a general developmental assessment at 4, 8, 12, 18, 24, and 30 plus months. And then you have to go in for a hearing assessment, a vision assessment, and a thyroid checking. I hope all general pediatricians can do this in your OP itself. If you are very busy, then you can probably keep an assistant for the development assessment. You can use the DDST or Denver 2 or any such models as screening. Now, then you have to do what is called as a developmental screening for autism with any validated tool. Say, for example, the Trivandrum Autism Behavior Checklist, TABC, is one such good tool, or the ISA can be used. Once you come out with the what you call suspicion of autism by using the tool, then you have to refer for a proper diagnosis and workup. Here, when I say refer, I am not telling that you should straight away send for a speech therapy. What I am trying to tell you is you should send the child and the parent to a developmental pediatrician, or if you do not have a developmental pediatricians in your area, since I'm talking about resource limited settings, I want each pediatricians over here to apply the basics of development that we have learned during pediatrics, and then do a little bit research, topic research, and help these children. Now, so what is required here is you have to discuss, intervene, and you have to give a clear summary to the parent. You have to sometimes tell about the developmental assessment outcomes that are there in their book. Somebody might have done it, but nobody might have explained it to them. And you have to counsel them and follow up. Mind you, you do this patient is going to come back to you for your vaccinations, for the fever, etc. Also, don't think that, oh, this is difficult, I will leave it. In fact, there is every chance that you can retain the patient for all the practical purposes by this way. So when you take up the what you call minimal assessments that are required in this particular diagnosis, is you have to go for what is called as a clinical history, a good clinical history. Antenatal history, natal, postnatal, a 3-generation pedigree chart you can take. And Soames sir has already talked about the autism symptomatology. How do you identify that? Well said about the symptoms. Now, autism, you have to do what you call as an assessment of the developmental level. What is the developmental level of this particular child? And what is the expressive and receptive language? That's all you have to do as a general pediatrician. You can have the Denver or the TDSE, and you have got the LEST, which gives you the expressive and receptive language skills. That's all, just 2 charts, you keep a scale and you will get it. So you can do that thing with minimal assessment in your OP. Then you do a physical examination and a sensory examination with focus on hearing, vision. And if you're not good at a neurological examination, probably you can do what is called QNST, quick neurological screening test. It's a questionnaire checklist. You can do it very quickly. So that also will solve your problem. Now you have to take about the emotional and the behavioral problems that Dr. Soames was talking about. You can note it down in your notebook so that you will address it subsequently. Similarly, information about socio-environmental factors. Now this autism is having a genetic predisposition, but it's the epigenetic factors and the environmental factors that does the second hit and make this disease so severe. So we have to have an idea about the socioeconomic environmental factors. You can probably do what is called a home screening questionnaire developed with the Trivandrum group. For this particular purpose, it is easily available also, free of cost. Then when you talk about the history, you have to have certain points in your mind. For example, nowadays we have found out that diabetes mellitus, maternal autoimmune disorders like antiphospholipids, thyroperoxidase antibodies, preeclampsia, maternal infections like rubella, cytomegalovirus, all these things are known to be associated with damaging the brains of the fetus. Prolonged fever and maternal inflammation will cause the cytokines to cross over the placenta and affect the developing brain. And among the drugs, most of us will write valproic acid for seizures. Now, this is one which will definitely cause autism in at least some 15 to 20% of the pregnancies if you are putting it quite early. In fact, in my PhD thesis, this inducing autism in Wistar rat with valproic acid and then assessing comparing the neurobehavioral behaviors of this Wistar rat with the human what you call autistic manifestations age appropriately was done. So I'm direct privy to this information regarding valproate. So also this misoprostol that you commonly put for what you call abortions. If the child has not got aborted and is going to continue, you are going to probably land up with some problems like this. Then Ssri that you put for depression. Now, quite recently, I have gone through an article where you find that paracetamol and beta-2-adrenergic agonists have been lately associated with increased rate of autism. But I'm putting a word of caution here. It is preliminary and inconclusive, because I'm bringing this point to your friend, that's all. Now, there are other things like heavy metal association, folic acid deficiency, etc., etc. Well, I am concentrating more on developments. So why developments? Because even if you see the developmental profiles of these autistic children are often very uneven. And so you cannot go ahead with an IQ. The IQ assessment will not help that much unless and until you are dealing, want to distinguish between GDD and plain autism. The score is less than 70, you go for GDD. If it is more than that, you probably go for autism. Other than that, if you take the IQ, there is a verbal IQ and there is the performance IQ. Obviously, the verbal IQ will be low. So the overall IQ figure, that's a combination plus, that is verbal plus non-verbal performance IQ, together will not adequately reflect that particular child's functional ability. So a better way for you will be to assess the relative strengths and weakness. Now you will tell, I don't have time for strength and weakness assessment. It's okay. There is a questionnaire called Strength and Weakness Questionnaire. You can take that question, it's freely available. You can take the questionnaire and give it to the parent when they are waiting in the waiting room. So by the time the parent comes to you, you have got a good idea about what are all the strengths and weaknesses of this particular child. And why is it important? That's because if you have the strengths, you can recommend the appropriate strategies to overcome, minimize, or probably circumvent all these difficulties these children will be having. Now, a little bit about the recurrence risk. There is a 10% recurrence risk of autism if one child is autistic. Now, there is a 20 to 25% of risk of other neurodevelopmental disorders also in the siblings. This is something which we have to take care. And if there are 2 autistic kids in the family, then the recurrence risk increases to 36%. Now, this becomes important for giving counseling during this sessions as they come. I thought the MChat will be dealt with the initial presentation, but unfortunately it's getting postponed. Anyway, I'm leaving it to him. There are other things like screening tools, like for example, Trivandrum Autism Behavior Checklist, which I told you. Quite recently, IAP has come out, rightly so, with a pictorial tool for autism. It's the English version is available. I think in the last conference they have released it. And our current president, Dr. Sabir Ahmed, was behind making this particular tool. I have made the Tamil version of it. If any one of you want it, you can directly mail to me. I am open to it. I am open to even giving it to the IAP or through the government, distributing it throughout Tamil Nadu. This is a validated one. Now, coming to the next one. So from screening, you use either MChat or you can use a TABC or NDD or any of those tools, NDD, the spectral tool for autism. For diagnosis, you have got different options. One is the INCLIN tool for diagnosis of autism. The other one is Autism Diagnosis Observation Schedule, ADOS2. Then ADIR. We have got the ISA and the CARS2. Among these, the ones written in red, that is INCLIN tool and ISA, are the options which are free and Indian. If you fancy spending out 2 lakh rupees, you can buy ADOS2 and make the diagnosis of autism. All right. The INCLIN tool is what I have shown right now. It's just a set of questions. There are section A and section B. And you are having the social interactions, the communication and restricted behavior. So you will be scoring yes or no, and then you come to the total of all the points and you make a diagnosis of autism or not. But this INCLIN is currently not based on DSM-5, it is based on DSM-4. Soon they will be revising it. But yes, for the diagnosis of autism, INCLIN is accepted. Now, a word about ISA, Indian Scale for Autism Assessment. That is a 40-item scale. You've got 5 categories which are written there. And since there are 5 categories, you will score from 1 to 5. So the minimum score will be 40, maximum score will be 200, which means if the score is less than 70, you're dealing with a normal kid. If the score is more than 153, you're dealing with a severe autism. Now, this is a scale that is used for certifying disability. If your score in this is 70, then you give a 40% disability. If the score is above 158, you give a 100% disability certification. This is also available free of cost, and you can get it even from the net. Now, coming to the management in a nutshell, you do first what is called as a pre-treatment assessment, which I have elaborated right now. And what you have to understand is each child is different, each family is different, each father is unique. And therefore, we have to deal with these people individually. There is no single package solution for the family or for the autism in general. So we have to focus on the individual strengths. What will be glaring is the limitation, and we have got a tendency to pick up the negatives. So please see the positives of the child, because that is what is going to kickstart your success in dealing with these kids. You work on a kid, you tell you are so beautiful, the person will be looking at you. But if you say, from where did you get this shirt? Probably they will not be inclined to listen to you. So like that, you work on the strengths, you use the strengths to overcome the limitations. They will be having some abnormal behaviors. So your intervention should be based on functional analysis of the behavior. Why this is important is because a behavior is always a product of a skill deficit. And if there is a skill deficit is always a product of sub-skill deficit. So you have a behavior, like for example, I want to scoot the examination. I am not going and writing the examination. What's the problem? I might not learn properly. I may be having examination anxiety. So that is the skill deficit I am having. So you identify the skill deficit and correct it, their behavior automatically changes. So that is why such a thing is important. Now, as far as possible, your OPD, etc., should be autism friendly. What I mean is like what Dr. Soam said, it has to be least distracting. You should not be having too much of crowding. You should not be having too much of noise, too much of bright lights, etc. So make it more autism friendly. Effective treatment is not determined about by how much time you are, the number of hours you are dealing with, or by the number of sessions. It depends upon the quality of the intervention that you are giving. It also depends upon the particular methodology that you are selecting. Round the clock, it is not possible. I understand that. So another thing is reassessing the professionals. Quite often we come across children who will be taking risperidone for quite a long time, or undergoing occupational therapy, like for example, putting beads for the last 2 years, the child should be sitting and putting the beads. So you as the fulcrum of treatment for these kids, I'm repeating it, you are the fulcrum, the general pediatrician or the development pediatrician who is dealing with these kids. It's the fulcrum of management of this kid. Let it sink into your mind. You have to decide as to how much each thing should go on. It cannot go on indefinitely. And then a role for counseling, right? So since this is continuing throughout the lifetime, you require what is called as a lifespan approach. That is, you maximize the potential and minimize the barriers. Okay, and this has to be for inclusion in education, inclusion in work, and and inclusion in society. So you start from toddler age group or infancy. What will you do? You provide some practical advice to the parents, to the educational staffs, or to all significant. What do I mean by this practical advice? You should be wondering. Like, for example, if somebody is telling you, teacher telling you, okay, green, orange, red cups, you stack the cups. This is activity for your parental training program. You go keep and do it. My question is, what the hell is this child going to learn if you simply allow them to stack up? They are quite good at it because they have repetitive behaviors. They will stack up, then they will become masters of stacking. Are you going to have master stackers? No. The thing is, what you have to do is you should be rather telling the parent, use your tumblers that you use for drinking tea, coffee, etc. Put paints, red, green, blue, red for the older one, green for the middle-age group, and yellow for the younger ones. Stack it up. By doing this particular stacking up, what are you doing? You are encouraging color concepts. You are, of course, fine motor skills stacking it up. And you are also bringing in the concept of older to younger. And finally, the mom is very happy because after stacking, the tumblers or the cups come to the kitchen. The job is served. This is what I mean by practical advice to the parent. And this is what we have to concentrate when you are giving the parental training or advice for doing things at home. Now, you have to follow what is called as a formal assessment for the child's developmental level. Why is it important? That's because you are going to implement general strategies based on the typical developmental trajectory. Now, if you do not follow it, you may be giving a home program. The home program will not work out. The therapist work will not work out. Why? Because you are going either above or below the developmental trajectory. It will not work out because it will not enhance the learning. It will not help the child to acquire the skills. And therefore, at each level, developmental assessment is very important. That's again the role of the developmental pediatricians. I want more pediatricians to come forward and become developmental pediatricians also. You address the specific social, communication, and behavioral challenges. For that, what will you do? You have to structure the sessions individually. And how do you implement it? In naturally occurring opportunities throughout the day, whenever you get opportunity. It cannot be like, okay, at this particular hour, you sit in front of me. That will not probably work out when the child is irritated. So but in this infancy and toddler age group, what you have to, whatever activities that you're doing, you should concentrate on three things: joint attention, engagement, reciprocal communication. So all those things that you're planning at this particular age group, these three things should be involved in all the different goals that you are doing. And you have to finally consider that the child is a living entity, and you have to consider in him in his entirety. You should recognize the value and recognize the effort of the parents. Even if they're putting little bit effort, pep them up. They will be more receptive for your advices. Now, if it's a school-age child, you will have to give some special support. Your teachers has to be made more aware. You should be having more resources for small group or individual education. Now, this may not be possible in our villages. So what the hell we will do now? What we have to do now is to focus on building bridges between community and specialist provision. This is the role of organizations like ours, IAP, or the NGOs, or now we have the DEICs, which are working a fantastic job in the different district hospital levels. So for all children with special education needs, we need adaptations, and these adaptations for general curriculum. So if you want to adapt for the general curriculum, automatically teaching methodologies also have to be changed for them. Now, in a typical Western world, if you are going to do the autism testing, we'll get a battery of tests, battery of things like MCHAT, CARS, EDOS, MRI, EEG, followed by a battery of genetic tests. Maybe at least a microarray will be there. But can we do all these things here? In resource-limited settings, obviously not. So then why should we order for investigations? It's probably because we can identify a syndromic and a non-syndromic ASD. We can identify conditions which are predisposing to worsening of the conditions which mimic autism spectrum, or we can assess the comorbidities, the impact, medical and neurobehavioral comorbidities, and how it is impacting the child. So also, we can also assess the impact in subsequent pregnancies, or even in the same child, how it is affecting them. Again, the caveat is investigations are not diagnostic of ASD. No biomarkers have been identified so far, though we are nearing to finding a biomarker very soon, maybe in few months' time. The phenotype identification. Now, this is what a general pediatrician can do. Now, you do the physical examination for minor physical anomalies and significant anthropometric measurement abnormality. So for each of these minor anomalies, you put a score of 1, ocular hypothyroidism score 1, macrocephaly score 1, single palmar case put a score of 1, and then if there's a major congenital anomaly, you put a score of 2. So you add up all the points. If in this autistic child, the score is between 0 to 3, you call it as essential ASDs. If the score is more than 5, you call them as complex ASDs. So 20% of the autism children are complex ASDs. So that makes it the workup very simple, especially if you are planning, if you have got some provisions for doing a genetic test. I don't fancy doing genetic tests, by the way, but still, for completion's sake or for getting escaping from litigations, if you prefer being so, then do it. ASD with history and record review, you see, you classify as essential ASD or complex ASD. All girls and boys with unexplained ASDs falling into ASD, you can go in for a microarray. Girls with intellectual disability, probably Rett, you can go in for a MCPT. Girls and boys with big heads, probably P10 testing with macrocephaly, that could be the cause. None of these, go for whole exome sequencing. In the complex ASDs, if it is a syndromic one, for example, Down syndrome, 5% do have a predilection to become autism. So you can do what is called targeted testing of trisomy. Now, there is no syndrome, again, the microarray. So in nutshell, microarray is the genetic investigation of choice if you want to order one. But I will not prefer it for all children. Why? Because DNA changes are found only hardly in 10 to 20% of children with ASD. In those who are having a predilection for this particular problem, for example, Down syndrome, 5%, or for tuberous sclerosis, it is 60%. Now we know for which you have to order the test, tuberous sclerosis or Down syndrome. Obviously, it is tuberous sclerosis. Again, chromosome microarray is the investigation of choice. Now, I talked about Fragile X. It is 1 in 100 of them will have ASD. How will you identify? You get to elongated face over there, a prominent chin, a long forehead, a protruding ears with simple helix, and intellectual disability with autistic features. When they become adolescent, they may develop macroorchidism. These are some of the clinical features which you can pick up just in the OP itself. And if you want, you can order. Otherwise, if it is not possible, then you have to leave it at it. But you have to make a note that you have counseled the parent regarding this particular possibility. But yes, clinically, you can distinguish an autism, typical autism, from a Fragile X with autism. In a typical autism, they will have mild to severe symptoms, and their social indifference is very, very glaring. Whereas in a Fragile X with autism manifestation, severe manifestations are relatively very, very rare. They may have social anxiety, they may have extreme shyness, they may have gaze avoidance, but they will have a very strong willingness to engage socially in spite of all this. That distinguishes the autistic behavior of Fragile X from a typical ASD. I'm not going too much into the syndromes for one of time. I'm straight away going into conditions which are predisposing to worsening, because there you can order some investigation. You should go for hearing and vision screening. Better if it is positive, you have to go for hearing aid screening. You probably have to go in for intrauterine infection testing. Please do not do torch titers, do separate titers, especially if it is congenital cytomegalovirus. It causes progressive sensorineural hearing deafness, hearing loss. It may be mild now, at later time it will become severe. So have a baseline titer and have a baseline BERA. Similarly, visual impairment. Please do not just like that send for testing of the vision for the power of the lens, etc. You have to send to a, if it is available, if possible, to a pediatric ophthalmologist, because the ones which are written in red, identification of optical illusion, test of emotion, ocular pursuit, saccade, size differences, visual, all these things are glaringly absent or problematic in autistic children. We learn through our senses, primarily through vision and hearing in the initial years of life, and deaf, and later only mostly through hearing. So if the primary two sensations are affected for learning are affected, then obviously I am going to learn differently. I am going to see differently. I am going to look through the corner of my eyes. I am going to close my ears. All right. It's as simple as that. So get it done. And then iron, as you all know, iron is an important component of respiratory chain enzymes inside the mitochondria, which is the what you call the power center of your cells. And these are also the power centers of the neurons. In the neurons, you have them in synapses, and therefore, if iron is deficiency, It will manifest outside as irritability, hyperactivity, inattention, etc., etc. Pep up the hemoglobin, you will prevent a lot of problems. Hypothyroidism, you have to do a hypothyroid profile, and if there is deficiency, you have to supplement it. In fact, congenital hypothyroidism is a working model for what they call non-genetic model of autism. So when they were making models of autism, they were inducing hypothyroidism in the young rats to produce autistic models. Lead as such will not cause autism, but it will aggravate the symptoms and it will prevent the learning. As you know, lead will decrease the iron levels. In GIT, nowadays they are telling gut-brain axis, etc. You may have cow's milk protein allergy, gluten allergy, etc. like in other children, but since they cannot express outside and their behavior will worsen, the autism symptoms will worsen. Metabolic disorders, I do not fancy doing it. The tandem mass spectrography yield is less than 5%. So, but if you get recurrently the child coming down from its levels, falling sick quite often, and the parameters are also, the assessment parameters also come down, in such situation with multi-system involvement, if it's there, you can order. Otherwise, just leave it. Comorbidities associated with this. Medical comorbidities, neurobehavioral comorbidities. 40% do have EEG abnormalities, epilepsy associated with that. If they are symptomatically treated, if you find an unusual deterioration in the skills also, you can probably start anti-epileptic. Do distinguish it from Landau-Kleffner syndrome, because there you have seizures. Following seizures, the speech stops. There will be some motor anomalies also associated with that. So that distinguishes it from autism, where the speech will be and the communications will be affected before itself. If you find neurological abnormality, do the imaging. MRI is the preferred one. If you find congenital abnormality, do USG and echo. Apraxia of speech is associated in 40%. Neurobehavioral, you find intellectual disability, anxiety disorder, sleep, you can put melatonin for these children. ADHD, demand avoidance syndrome. That's an interesting thing. Now, if the mother will be telling, okay, my child is very good at doing some Lego toys, and when the mamiar or mamanar comes immediately to show her skills, the parent will tell, the mother will tell, and the child will throw away everything. This is what is called demand avoidance syndrome. Of late, we have been, this particular terminology has come into existence in our literature. Post-traumatic stress disorder is also seen very commonly. These will aggravate, or these are also associated with that. The MRI findings are increased volume of brain, particularly in under 6 years. You can see the difference in the brain. There will be increased volume in the frontal and temporal lobes. The thickness of the frontal lobe also is increased. You can get increased CSF. There's a decrease in volume of cerebellum, decrease in or thinning of the corpus callosum. So if you are private to getting these things, if your neurological examination suggests something like that, you can do it. If you expect a gray matter problem, that is seizure, etc., go for structural MRI. If you are expecting a white matter problem, go for diffusion tensor MRI. If you want to do research as to what is the result of my intervention, go for functional MRI. Activation of neuron over time, you can see it. Okay. So what you are seeing here is what you call as a temporal pole anomaly that you can get in the autistic kids when compared with the normal. The mesolimbic pathways, you can see it. It is extremely thin in the case of autistic kid. That makes the social interaction less rewarding for these kids. Right, when you come to the management, a lot of management is there. It starts with behavioral therapy, discrete trial therapy, pivot response therapy is there. Then you have got medicines, risperidone, aripiprazole for behavioral abnormalities. If there is sleep problems, put melatonin. Older kids, you can give, if the IQ is a little bit higher, you can go for cognitive behavioral therapy. If there is fine motor limitations or sensory issues, you can go for occupational therapy. Communication, speech and language problems, speech and language support. Education, special education support, balancing and clumsing, go for physical therapists. In fact, there are different programs combining all these things, what is called as SCURT programs, EIBI, ESDM, TEACH, etc., etc. All these things are Western programs. They are available. But the problem with all these things is the cost. But mind you, the developmental pediatrician is the person behind it. How will you do that? You have to adapt it. How will you adapt the evidence-based intervention to a low resource setting? How will you make a non-specialist worker understand and deliver these services? The way forward is called parent-mediated intervention. Here, you shift the task to non-specialist health workers, and they have found out that it is giving encouraging. Should we go for our ASHA workers or ICDS workers for this? I believe no, we have got better options. we can go for what is called developmental therapist, developmental nurse counselor model with DP supervision. In low resource settings, we have got the Rashtriya Bal Swasthya Karyakram, which is having a good thing by you can monitor the neurodevelopmental disabilities during this particular. MKC Search has come out with the Trivandrum Development Screening Package, where the development therapist pediatrician team can work together in resource constrained settings. The team will be introduced to the mother at the center level. They give simplific, scientific, specific interventions, and the mother will go to home and do it. The child will be monitored at the center. There are different packages like NIMS, CDRC model, clinical-based, home-based interventions. You can avail those facilities. The way forward is AIT, awareness about autism, so that the stigma is reduced, discrimination is reduced, community engagements is there, inclusive education, so investment on that. The potential for virtual early interventions, especially if autism services are scarce, you can go for that. But again, you have got the problems of inadequate availability of electricity, electricity shortage, digital devices may be less, human resources for training maybe, all those things are limitations. So I go for a developmentally based social communication therapies where the focus will be on adult and child synchrony, learning to respond to the child's cues, shared attention, child initiations, and spontaneous play. That we have to do. Other interventions are EIBI, what's called applied behavior analysis, natural linguistic development. All these things are Western programs, and if you are privy to that, you have to do. Whatever interventions you are doing, please have a look at this particular slide. At 2 years, if you concentrate on repetitive behaviors, delays in expressive language, you are going to have a direct better outcome in the adult phase on autonomy, independence, community participation. 3 years, higher ADO score, community social skills scale, you are going to have a direct implication on adult outcome. Delayed adaptive skills at 4 years, similarly 5 years, high verbal. So if you are intervening, that's why I'm calling for a developmental model. At 2 years, 3 years, 4 years, 5 years, you concentrate on these things along with other supports, you are going to have a better child. That explains probably why Dr. Som's child in the video that he has shown had a better result. Now, is it possible? Yes, throughout the life it is possible. Why it is possible? Because it is a genetic, neurobiological and developmental model. There will be preschool developmental problems, there will be childhood developmental problems, there will be adult development problems. If you give more positive things, you will get more positive outcomes and less negative outcomes. So that is how from preschool to adult, this level of support goes. In the preschool, you find families giving more support. As you come to the older, you find the school and the community that is giving more support. Now, the developmental model, the aim should be that parent should adjust the style to the communication level of the child, which means if the child is telling in 1-word sentence, you should talk in maximum 2-word sentence. You cannot tell Kana inga vada eduthu vada, you cannot tell, the child will not wait. Inga va eduthu kudu. Like that you have to tell if it is the verbal level of the child is 1 word. Similarly, what we have to do is we have to focus on natural interactions. And you have to recognize and respond to the child's non-verbal cues, because first the non-verbal cues come, then only the verbal communication comes. You have to modulate the child at every level of support. You have to build on the parent skills, make parent independent, make them capable of making independent decision as far as even the goals are concerned. That is the way forward in resource constraint settings. Probably you can go for video-aided feedback also. Now, the follow-up you have to do is you have to do reassessments. Autism treatment evaluation checklist, one good online score that you can do for all autism treatment, including sensory evaluations. So I'm not putting the sensory evaluation separately. I'm putting it as attack. For development, you can use any of those scales. Core symptoms go for CARS and ISA. Behavioral, you can use CBCL2. Adaptive, use Vineland 2. Speaking language, Wales, less, or any of those things you can do. You explain in detail when you are giving the counseling, improvement, etc. Follow the IMNCA's LPAC model, ask, listen, praise, advise, and check understanding when you are giving the counseling. That will give you better results. The other services which are available are speech therapy, occupational therapy, sensory integration therapy, music therapy, hippotherapy, dietary interventions. There are a lot of interventions that you can see in the net, but much of these things are not having any direct what you call RCT other than ABE. When you say sensory integration therapy or sensory modulation, do you need this much? When you are having a kinetic sand, which will cost you some 600 rupees for a small 100 milligram, it will be written like amazing results, good physical development, etc., etc. Can't you take your child to the shore and make them write A in the wet sand? Do you want an iPad to write B inside the slate, in the image inside that? Can't you buy a direct slate and do it? Our Tatangal is a very good thing for hand-eye coordination and concentration. Can't we do that? Similarly, baseball or cricket, okay, fantastic hand-eye coordination exercise. Can't we play gilly? It is the Indian cricket that will give you good hand-eye coordination exercises. Center-based vestibular stimulation, they will say you should get some 4,000, 5,000 rupees for that swing, and for that session another 200, 300 rupees. You can have it in tied on a tree, and you can have it naturalistic way. Similarly, sand trays, they will say non-verbal approaches involving use of miniature toys, etc. Why should you spend so much when you have the Kichu Kichu Tambalam games? You can keep those things underneath the sand, and you can do the same thing, imagination, sensory stimulation. So many things you can do with that. Musical chairs. Should you buy so much colored chairs when you have got the option like this available in open air? And similarly, clay activities. Why should you spend 250 rupees for a 100-gram therapeutic when you have the natural play? You can change the amount of water that you're adding, add few colors, watercolor to that, and make it tough or thin. And you can give the clay activities, the tactile issues, strengthening the hand muscle, different pinches. All those things you can do with the natural play. A center base. Do you require the child to come to the center and throw a ball like this? Can't you do it? Okay, you can tell object control, propulsive skills, whatever technically you want to call it, but we all have it in nature itself. Throw a game, similarly, hand-eye coordination. Our Kaladital game, the 7-stone game that you commonly play in villages, excellent for the same results. Stepping stone, 11,000 to 16,000 rupees is the cost of that. You've got the naturalistic way, balance, obstacle course coordination. That is the aim of that. So we have it, everything. So my dear friends, what I am concluding is, in the search of gold, we have lost our diamonds, our Tamil Nadu diamonds. It is time to bring back those diamonds for our children in the name of therapies itself, and to be implemented in a guided way by the caregivers. I am inviting like-minded partners among you to send to me such activities, if possible, videos. Together, let us make developmentally appropriate traditional games, culture-wise itself, state-wise if possible, and with targeted goals, and let us submit to the experts in the IAP. Let us not detach our profession and crib that we are having resource stimulation, we are our child is understimulated, etc., etc. Enough is there in nature, enough is there in Tamil Nadu in India. Let us get all these things codified, and let us make something new for our generations to come. If you're having any doubt, please contact me in this number or in his email. If you are having anybody who is especially staff nurses whom you want to train in early interventions or in autism early interventions, please contact me. We are giving a 50% fee sponsorship. My foundation is giving. If you are getting trained in Savida CDC, I welcome you people to send your most trusted staff nurses, or for that matter, anybody who are going to help you to us. You can write to info@vistarafoundation.com. Thank you.
Thank you, Dr. Lal. That was a very, what shall I say, exhaustive discussion. And I mean, you made us realize that there are lots and lots of opportunities for these children, and also for the staff, training them, because we should know the right way to do things. And, the parents are kind of just deposited those children's lives in our hands, and it's up to us to do the best. And RBSK, of course, is doing a good job, as you rightly mentioned, and cost is a factor in the private setup, but still we all have to join hands and get things done for them. I'm sure there are questions. You'll have to wait till Sudhakar's session is over.
Yes, ma'am. One thing more, madam. Please send the enquiries through SOMSARS or IAP for the training if they are required for a 50% reduction in fees, which we are sponsoring.
Okay.
That's for the audience.
Thank you so much for that. And how many students, I mean, how many people do you train at a time?
We can train 10 at a time.
Is it over how many days?
It's a 1 year full program. In-house program we will provide for accommodation also, and we will give the degree from the university.
Okay, and the degree is?
It is a master's degree. You can have a certificate and a master's. Master's is 2 years.
Oh, okay, okay. Do you have any short courses? Short.
We have a certificate course for 6 months is also available.
Oh, okay. So we'll keep that in mind when someone's interested.
Yes.
So now, Sudhakar, ready?
Yeah, I'm
I will
going to
present these
present with the
slides.
support of Dr. Somasundara, madam.
Yeah, Dr. Lal, can you stop so that I can share Dr. Sudhakar?
Yeah.
Excellent presentation.
Yeah. There's a totally different perspective for all of us.
Am I visible, madam?
Yeah, you are visible. Sir.
Stop sharing. Lal has to stop sharing.
Lal has to stop.
Good evening, every one of you. I
Yes.
thank for the opportunity. Of course, my sincere apologies for not able to present it. Okay, let it be like a sample or model for the.
Not like this, yeah.
No, Lal has not closed his search.
Yeah.
Thank you. Thank you. Please go ahead, Sudhakar.
Yeah, this is.
Sudhakar,
it is more
introduction.
like Sudhakar.
I introduced him already, but I'll do it again. And
No, madam. Better go.
passionate development pediatrician, an excellent worker, in IAP and also in all the programs that I've had in ICH. And I'm really thankful for people like you to carry the program forward. Please go ahead, Sudhakar.
Thank you, madam. I would say that my presentation, my situation itself is an example for an autism where I have the content, but I'm not able to communicate to you in a proper way. So that is the core problem in autism. The child may be intelligent, the child may be knowing everything, but still the child is not able to communicate in a proper way actually. And that is where we have to understand the problem. Otherwise, it is very, very difficult to convince the parents about the diagnosis, even not a diagnosis, even a suspicion. There comes the pediatrician, because we are the first responders for any parent actually. So whenever parents comes with you, they will have children with speech delay. For them, it is a simple speech delay. Why this question arises? Many times people, even if you want to convey the message to the parent, they won't be ready to accept it because the child will be doing all the other development like gross motor, fine motor, all the other domains the child will be doing. So they simply take it as a isolated late occur syndrome or expressive speech delay. And another confusion where it starts is the child will be able to fulfill his needs by communicating. So there is it behaves like a split personality. The child will communicate to the mother in some way for his basic needs. So the mother is convinced it is just a speech delay. So for that, a pediatrician should understand how to convince the mother. So what is that? Usually we talk to the parents in a subjective way, which may not be acceptable. So let us go in an objective way that where we use MChat. It is a very, next slide, please. So I'm going to talk, next slide, please. So I'm going to present two MChats. Usually our practice previously. Usually we always said MChat means one. For the beginners, I'm telling there are two charts available, MChat or follow. So if you see the difference, MChat are questions, 20 questions with the answer yes or no. Whereas MChat or follow have pass or fail. Next. So MChat per se is a two-stage parental questionnaire, but it is in English and it has been converted, translated into Tamil. Still, our parents are not able to answer. I'm going to talk only about the practical problems as a development coming across when I'm applying MChat. So parents are really not comfortable in understanding the question. So we have to support them in Indian scenario. So stage one question is MChat-R. That is MChat revised, modified checklist for autism in toddlers. It is going to be used in 16 months to 30 months. What many times have seen children being undergone MChat after 30 months, 2.5 years. 3 years, 3.5 years. It's not right, but why it has not been validated? That is one simple reason actually. We have other tools for, but let us concentrate only on the MChat tool. So first you are going to do MChat-R. In that MChat, so all the questions are having yes or no. So the no carries the 1 point actually, except question number 2, 5, and 12. The 2, 5, and 12 carries a mark or a number or 1 point for yes answers. So for 1 to 20, except 2, 5, and 12, all the questions, if the mother or parent say no for that, then you mark 1 point for that. For 2, 5, and 12, if the mother or parent says yes for it, you mark 1. Next. Next. So that is how our scoring system. Next. So I have already told MChat R is stage 1 and yes or no. MChat or F is stage 2, is either pass or fail. Next. So now we are going for MChat R. If the score is coming as 0 to 2, that means the child is having a low risk. Here, if the child is younger than 2 years, you have to screen again after the second birthday, because we all know in autism, there will be regression of the milestones, especially social communication and language milestones. Many times, mothers, if you ask, Pesarana Kolanda, did the child talk? Mother will always say that, Ama sir, Amma Kutta, Appa Kutta. Now the child will be 3.5 years. Your question is simple. The mother says, yes, my mother. When it called now, whether now he is calling, mother may not be able to answer. She'll say 1 year, by 1 year, 1 year, 3 months, he was telling. After that, he stopped. For her, it is achieved, but now he is not doing, we are not calling just for adamancy, or she will be giving a lot of justification for that. So be very clear in it. So 0 to 2, low risk. If the child is younger than 2 years, you need to screen the child again, but there is no need for any further assessment or any therapy. Next slide. Now comes 3 conditions. Medium, total score 3 to 7. Here you need to follow up to administer the follow-up actually, MChat or F. Whether I have to do the complete 20 questions? No, only where the question is, the child is giving and a mother is giving a no answer, you go to the particular question and do it in an elaborate way, help the mother. There you are going to give yes or a pass or fail. Now, I'm going to say that if MChat or score remains at 2 or higher, the child has been screened as positive. So here, what is the action required? The refer child for diagnostic evaluation and eligibility evaluation for early intervention. Many times we delay the therapy just for evaluation's sake. Better start the therapy, meanwhile you do the evaluation, because it is not like CRP altered by a steroid or something like that. It is going to be long testing. So your evaluation is not going to be altered by simply starting a therapy. If the score on follow-up is 0 to 1, there is no further action required unless surveillance indicates it. See, the thing is, many times it is based on always, but a physician's suspicion is always a golden thing. If still you are suspecting an ASD, please go ahead with your evaluation. Next, if the score in MChat is 8 to 10, it reads high risk. Here you have you can skip it actually. You can skip the follow-up. You can directly go for evaluation and start the therapy. Now, what are the practical problems we are undergoing in practical life in clinics actually? So, unfortunately, I'm not going to be able to present all the questions, but I will tell the questions. So the first question comes, next slide. Somastram, next slide. Yeah. If you point at something across the room, does your child look at it? The practical problem is mother always says yes. Yes, sir. Pakaran, sir. Pakaran, sir. Yeda pakaranga. The point is, many times, if the mother shows something, the child may not look at the object. It will be looking at the mother or her finger. So always the question should be very specific, whether the child is looking at the object or pointed to the object And whether you can ask the question, whether you asked about that thing, whatever you are pointing out actually. So how the child will fail when the child is considered as a fail? If the child ignores you when you ask something, many times children ignore. 90% of children ignore whenever you say something. So they ignore, or they may look around randomly, or they look at your finger. That means they are failing it actually. Even one failure is considered as a fail. So the next thing is, it is related to the deafness. You reported that you have wondered if your child is deaf. What led you wonder that? So the thing is, many times we ask parents, this question, 99% mothers will be, no, sir. அவனுக்கு நல்ல காது கேட்கும் சார், because அவன் எங்க இருந்தாலும் wherever he may be, whenever the advertisement, he runs away. So the point is actually it is not about hearing, but of course we have to check the hearing, because to rule out the other problems which is presenting like an autism. But the question is not about the hearing, it is about the ignoring, whether he is receptive about hearing. So whenever you call him or some, whether he ignore the sounds as well as he ignores the people. Many times children may ignore the people but not ignoring the sounds. Here comes the problem. They always answer, அவனுக்கு நல்ல காது கேட்கும் சார், ப்ராப்ளமே இல்லை சார், அவன் ஓடி வந்துருவான், எங்க இருந்தாலும் டிவி போட்டா வந்துருவான். Next time I have to say, whenever name call us, whenever I call his name, whether he ignores it or not, if he ignores even your call, that is also a failure. Then next, actually, pretend play. Many times we forget, sir, as Dr. Lal mentioned, we have forget our traditional gift, choppu jaman solluvom, that will easily make out the diagnosis. The child has to present with pretend play. Empty cup la irundhu kudikirathu, doll la vandu thala siivu vidradhu, powder podradhu, feed pandradhu, lot of things a child can imagine, the imaginary thing. It usually start 15 to 18 months. ரொம்ப டிப்பிக்கலா நம்ம அந்த காலத்துல செப்பு ஜாமான்னு சொல்லுவோம். அதுதான் that going to bring out the diagnosis actually. If the child has not have the pretend play, yes, the child is failing in that actually. Next, does the child climbing on things? Ideally, for this age, less than 3 years, children are supposed to climb on things hard. If the child is not interested in that kind of things, usually weekly they are always running here and there, getting on that, jumping from that. This all should happen. If the child is not doing that, then, but here comes a question. He may be climbing in the stairs, he may be climbing on the chair, but not doing in the furnitures or playground. There may be a lot of other things are there. If he is able to climb on or enjoying the climb, it is not ability actually, it is enjoying the climbing in the stairs or chairs. Yes, even one he is doing, please, yes, the child is paused. If the child is not able to do even in staircases, chairs, furnitures, in park, is not climbing on the slides, yes, then it is considered as a fail. So even in one thing, either staircases or chairs or furniture or playground, yes, consider them as pause. If he is not doing anywhere, he is not at all enjoying the climbing, consider them as a failure. Then comes, does the child have an unusual finger movements near his or eyes? Here comes a lot of confusion. Many times parents also get confused how to define, because in medicine we always have a very clear-cut definition for each and everything. What is flapping, up and down movements in front of the eyes without any, we can define, but a parent cannot define it. So they may have a lot of confusion in this question, whether the child is, only few percent of children have a typical flapping, but these children may have a fingers near the eyes, in the sides. They can present in many ways. They can hold their hands very close to their face actually. They'll be keep on looking at that, but flapping alone is not the thing. They can wiggle their fingers, they hold their hands very close and keep on doing some. It is actually, it is a symptom of autism. It's of self-engagement. It may be doing auto reinforcement or a simple self-engagement. It is a manifestation of an autism. Even if the child is doing any one of that, the child is failing. So next question is, does the child point with finger to ask for something? Again, this question, again, we have lot of issues. Mothers say, yes, he is pointing. what is finger pointing. We have to specifically say finger pointing, how he approach. Many times the child will go and show the hands, just shaking hands or raking hand, and just go take the mother to the kitchen and take her hand and show it actually. So we need to tell them what is finger pointing. We have to explain to the mother. If the child is not able to finger point, it is not like reaching with the whole object. We expect the child to go with the finger, point it with finger. And so if the child is not able to do it, yes, he is failing here actually. If again, then now we about, I think madam, I have time. Do I have time for all the 20 questions?
I will let you know, Sudhakar. You carry on.
Okay, madam. Okay, and another question, is the child is interested in other children? Again, this question, the parents always say, yes, sir, my child is very much interested. He enjoys his cousin or thing. Autism children will have a specific interest in, especially younger age or older age. Either they will be following someone they are interested, but they'll be very specific about either single or one or two children they are very attached. The question is about interested in the other children. It is not a single child. Because many times they say, because this question always takes us in a wrong way. So we need to know whether the child is interested in playing with other children, whether try to talk, communicate to the other child, whether he makes some work. See, he may be a non-verbal. That doesn't mean he cannot communicate. He can see the communication is always that verbal and non-verbal. You can communicate through your eyes, you can communicate through your facial emotions, you can communicate through your gestures, and you can communicate through your words. An autism child fail in all these things. A speech delay child may not be able to show his interest through words, but he'll be showing it through the eyes and body language. So you have to specifically explain to the mother that whether the child is interested and try to communicate with other children, he may create some noises, he may smile at the child, he may be very shy at first, then slowly go near the children and start trying to play, mingle with them, or even getting excited on seeing other children. If the child is able to do either one of that, please consider them as a pass. But the child is not at all able to do, yes, the child is considered failure. Many times in our own clinic, we have play area. We can ask that our attender or staff to observe the child, or you can ask the mother to observe and give the feedback about that behavior in that play area actually. Now, whether does your child show you things by bringing them to you and holding them? Here comes one. They always, sir, phone எடுத்துட்டு வந்து கொடுத்துருவான், சாவி எடுத்துட்டு வந்து கொடுப்பான், செப்பல் எடுத்துட்டு வந்து கொடுப்பான். The point is whether the child want to share with you his emotions, his excitement, or he is trying to fulfill his needs. Autism children bring things to fulfill their needs, but they never come to you to share their excitement. Here comes the major. You have to explain to the parents, it is not about the need, it is about the sharing their excitement. Even he may be bringing a toy, he may be bringing a picture, a drawing, or a flower, or even is a new pillow or new toy, something the child will come and give it to you. That means he's sharing your, because autism children lacks the emotional reciprocity. Then comes your child. Does the child respond when you call by her name? Yes, the child, this obviously many parents, in my own experience, name call response, most of the parents are accept, yes sir, he is not responding for. It is one of the easy question actually. Then smiling back actually, whether your child smile back to you when you smile. நீங்க ஸ்மைல் பண்றானா உன் குழந்தைன்னு கேட்டா, they invariably say, ஆமா சார், நல்லா ஸ்மைல் பண்ணுவான் சார். எப்ப ஸ்மைல் பண்ணுவான்? Whether the child needs prompting. Here comes, by many parents become naturally therapist. By the need, they themselves become therapy. They start prompting the child. Ssri, bye bye sollu. Whether the child is doing it spontaneously or whether child is doing everything only with prompting, this is a leading question we need to put. Whenever I enter the home, whenever the thing is, appa varanga, appa office mudichu varalam, or either the grandparents varla. It is not, the question is not about the strangers, only with the known people actually. When they come to you, obviously whenever you see a child as a human being, we always smile at them. If the child is simply staring at you and moving away, yes, the child is failing here actually. So whenever you, when you are visiting your cousin, he is maybe in the room, and you go and check his room, you say hi to him and smile at him, how the child react to you? These are the leading questions we have to put it actually. So if the child responsive, smile back. Many times I have asked the questions whether the social smile or smiling responsibly, because smiling responsibly means when I smile at a baby, the baby will smile back. The development happens by the age of 2 months. Smile spontaneously happens by 3 months, but many times parents are not able to recollect it actually. So at least by 16 months to 30 months, the child should be able to smile responsibly. Then comes the everyday. Does the child get upset by everyday noises? Again, this is a very big problem. Unless you put a leading question, they may misguide you actually. What is everyday noise? That's the biggest question. Noise கேட்டா குழந்தை என்ன பண்ணுவான்? ரெண்டு விதமா சொல்லுவாங்க. அவன் ஒன்னும் பண்ண மாட்டான் சார், ஒண்ணுமே பண்ண மாட்டான் சார், என்ன பண்ணுவான்னு எதிர்பார்க்கறீங்க. So I should know what is that actually. What is the hypersensitive noise? The child can present simply crying or blocking the ears, or simply running away in the place, or going and clinging the mother actually, or many situations. The child simply will be playing somewhere and the mixie is on. The child will come to the kitchen and look at that, stand for some time and go. Hypersensitivity doesn't mean always crying and throwing temper tantrums. Normally what we expect in children, if they are playing in room, everyday noise means the child is supposed to get adapted to that actually. It could be mixie, a grinder or whistle or anything, even a doorbell or anything. The child is not supposed to react for it. That continue it playing actually. If the child is sensitive, they always come and look at it actually. That is called hypersensitivity. Then comes, does walk? Why should it be the question? It's a very big question. Why MChat should carry, does the child walk? As Dr. Lal has mentioned, many genetic syndrome, you have to rule out other development delays, because many development delay children with motor, especially hypotonic motor delays, will present as an autistic. So they are present like an autistic-like presentation. So we need to think in that way also. So if the child is not able, then we have to think about either hypertonicity, a tone abnormality in children, or any brain malformation. We cannot simply carry by the diagnosis of autism. We have to look for some other features. Then comes, does your child look in eye when you're there? This again is a very big problem. Eye contact. Many times parents says, yes sir, papa sir, kanna papa sir. In texture, in our literature also, there is no definition for eye contact, continuous eye contact. We always simply say inconsistent eye contact. There is no definition to say 2 to 3 seconds eye contact or something. But the eye contact, what is eye contact? Is another non-verbal communication. When you need something, you are going to look at you. When you are going for a job interview or something, you directly look at the person. When you go and meet your teacher, you directly look at this. See, we want to communicate your emotions and need everything through eye to eye. These children will be lacking. But parents always say, kanna papa sir, adala kanna papa sir. Eppo paakara, whether it is a need base. When you call for milk, when you show biscuit or chocolate, many times parents say, ama sir, chocolate palgalam kuduka varumbodhu kanna papa sir kudu. So again, the child is autism children always that misguide us actually. அவன் உங்களை தான் பாக்குறானா அல்லது மில்க பாக்குறானா பிஸ்கெட்டை பாக்குறானா, we don't know. But the children always respond with a short eye contact of 2 to 3 seconds when something is given to him or his favorite thing is given. But again, it is inconsistent. The child is always having a fleeting. Neenga kutta kuda clinically, even if you talk to the child, call by his nickname or something, he will look at for 1 second and immediately he will look at somewhere else. So this is eye contact. So you have to be thorough. What is a proper eye contact? Then comes trying to copy. Whether your child is able to try to copy what you do actually. whether maybe stick out a tongue or it make a funny sound. You can say goodbye, you can say you clap your hands, or you can do something with your fingers, or you're blowing a kiss or something. If the child is able to do it, then either one or two the child is doing, yes, the child is paused. If the child is not able to do more than one or two, yes, the child is failing. What is important? Why that is very important for an autistic child? What is there in a communication? Autism children lacks the imitation skill. There comes you are different. Many times parents and many therapy centers will say, you play school potanalar. Many times parents also say that play school potanalar, sir. Therapy venuma, sir. Play school pota pesirana, sir. Children with imitative skill will learn from the environment. They normally, a typical developed children definitely is going to learn from the environment through by seeing other children through that imitative skill, which is obviously missed in the autistic children. So when the child is not to copy you, means it is the lacking in the imitative skill actually. Then comes if your child is, if you turn to look at something, that Dr. Somasundar beautifully talked about the joint attention. So this question is relevant to the joint attention. If you turn your head to look at something, does your child also look at that actually? So whenever you go to the corridor, balcony, if you imagine, obviously children also will come and the excitement இருக்கும். They'll come and joint attention. Amma enna pakranga, appa enna pakranga, avangalum paapanga. It is this question number 16 is going to say joint attention. So the child will be lacking in joint attention also. Then again, child is making you to try to get watching. That's attention. The child is trying to grab attention from you actually. But here, many times
slides are not moving, Sudhakar. It's in
Madam, that's why I mentioned, madam, we had a problem.
Okay. Sorry.
I'm sorry for that actually, but technical is, madam, I couldn't help myself.
Okay, fine. No, somebody was moving your slides. I thought, okay.
No, I was only presenting, madam, but he told he has issue attaching all the slides and sending.
Done. Sorry. I think I missed
only that. 9, out of 29 slides, only 9 slides are coming, madam. I don't know what.
Okay. There's something in the chat box also. Okay, fine.
Okay. So whether the attention seeking, it is lacking in autism children. They never look for attention. That they look for attention only for their needs by making an inappropriate way, like crying or rolling in the things, lot of things actually. And that is not the right way. They always have to come and talk to us or show their thing, just like an attention speaking, like any other child. If the child is not able to do, yes, the child is failing here actually. Does the child understand when you tell him something? This is again, many parents obviously say the child should are supposed to follow 1 to 2 step commands. Even one command they are not able to. Be very clear in 3 things the children will do this command, follow their command actually. It is like checking the remote, taking the milk glass or something, or taking the car key or helmet. The autism children always respond for commands which is going to fulfill their needs. So it is generally, it should be like, it's an order. Take the shoe and keep it there. Take the book and give it to mother. Take the phone and keep it there. Something like that. If his needs are not fulfilled, autism children never does that actually. So if something new happens, how the child is showing it to you actually. That means emotional reciprocity. If the child is not showing, if anything new, the child is not looking at you and showing the thing and sharing the emotions to you, yes, the child is failing at actually. And finally, does the child like movement activities? If he enjoying like தூக்கி போடுறது, நம்ம கால்ல வச்சு ஆட்டுறோம், ஸ்விங் பண்றோம், தூக்கி போடுறது, bounce or swing, if the child is enjoying it, passing. If the child is not enjoying it, may be due to hypersensitivity or it may be due to the problem, the emotional thing. The child may not be like to say many times the children with autism, when you hug them, they won't mind it. They won't mind it at all. Either they will go away from you or simply standing near you. Even though you are hugging and talking to them, they never talk back, they never smile back. They simply sitting or simply move away from that. If this happens, yes, the child is failing. There's a 20 questions, even 1 or 2 is the child. So 2 is failure. Please consider child is an autism child. In the case of at-risk or autism spectrum, send them for evaluation. The proper evaluation is ADAS. Unfortunately, ADAS is very costly, and in practical life, we are following CAR scale, which is very cheap and anybody can do it actually with a proper training. And moreover, I always want to say that in autism, that mother has to become a therapist. Please allow any center. Tell your mother, if the mother is allowed inside the therapy room, select the therapy room. Select the therapy, what is that therapy organization. If the doors are shut for the mother, let the mothers shut the door for the therapy centers. Unless the mother, because the right volume of therapy is 42 hours per week, you cannot bear that amount actually. Nobody can spend that much amount. And again, the basic thing is only one thing. They are all typically developed normal children lacking in the concept of communication. It is not communication alone. It is lacking in the concept of communication, whatever may be the therapy. If the therapy is going to help the child about the concept of communication, children will beautifully come down. As Dr. Somasundaram and Lal shared, is a lot of positive messages from their own experience. I also would like to say, our children have come out. We don't keep children more than 1 year in our center. After 1 year, we push the mother out of the center because we want to give more, accommodate more children. And luckily, these mothers are continuing therapy at home, and beautifully these children are doing in the school. And many times when they come back to our own clinic for illness, nobody can identify they had the problem actually. Only the parents and myself can understand the child had the issues. There may be, as the child grows up, there may be again little challenges will be keep on coming, but the mother should be equipped about to manage it because they cannot lifelong come to us. Autism is a lifelong problem, so equip the mother for autism management. Thank you. And once again, I sincerely apologize for my technical failure. I will try to do my best in the next time.
Thank you.
You were able to convey whatever your slides would have done, you were able to convey better. And that shows that you're, as PRC says, very effective communicator. And I think that's what the audience is also looking for. They just want someone to tell them how, most of them are thinking that if they do one MChat, it is easy to pick up autism. It is not so. So the child has to be observed over several sessions. And although we may be sure that this child is strongly suspect autism, it's not right on our part also to brand the child in the first few sittings. Still, we give them the benefit of doubt. So, were there any questions in the chat box? I was not able to make out anything.
Madam, one point I want to, sorry.
Yeah.
MChat, and again regarding to MChat, if MChat is pause or something, please don't tell the mother your child is having autism or something, because there is possibility, even though it is having a high sensitivity and specificity, there is possibility of false positive due to various reasons.
Yeah, that's what I'm saying. That's just because so I think Dr. Chendil had asked whether doing an doing an MChat once, whether we can just straight away say that this child has got it. No, but that does not mean that the pediatrician need not be trained in these screening tools. Every pediatrician should be very confident about using one or two tools to pick up autism and developmental delay. There is no two ways about it. Every primary pediatrician whom a child comes to for well baby visit has a moral responsibility to administer a screening tool. For that, they should be familiar with the tool. So they need to do it repetitively for them to gain confidence. Otherwise, they'll be reading each question so many times before they ask. So it has to be done, and this child has to be seen on repeated settings before we tell them that this is there. And therapy can be started from the very first thing. Something that a mother can do at home definitely can be started. We don't have to send the child to a center straight away. But that can be done with subsequent visits. Now it's over to the experts to, tell your point. One minute for each of you before we hand over the session to Uday Kumar.
Dr. Sendil, welcome, sir. Sorry, has he raised the hand? Sir.
Yeah. Very good morning, and an effective communication by all the three speakers. Appreciate all three of you. My question was actually, what was the exact etiology for autism spectrum disorder? Till now, what is the research says? What is the exact etiology?
We are not able to say that, sir.
Sir, still it is in the research, sir. Actually, I would like to share the good news from the government sector. Actually, now we are having a tie-up with New Birth. They have included autism panel also. So we may come out soon. We may come out with the result for this section, sir.
We know that
So
there is
still-
a genetic basis, Dr. Chandil, because we see it running in families, and we know that the risk increases with more members of the family being involved.
Especially twins, actually.
Nowadays we don't see, we are seeing a lot of cases, but it doesn't have any family member connection. That's what I'm trying to, is there any environmental factor, a genetic factor, and what is the root cause?
I think any of these environmental factors may uncover the defective gene.
So there are some around 100 genes which are directly as the causative of autism that has been proven.
Yes,
there are a lot of other genes are also which are associated with that. But the the model that we are currently supported by the experts is that it's a two-hit model. The first hit, we have got the genetic predisposition, following which epigenetic factors or environmental factors, if they act, for example, there is a genetic predisposition. Following the child is born as premature, that is the next hit that is getting. If that's the case, then these children are going to have an increased predilection to become an autistic. As such, in prematurity, if there is somewhere around 12% of the children becoming autistic, if it is around 25 weeks, whereas when it comes to 31 weeks, it comes down to 5% or so. So and that too for girl children, they are having more prone if they are premature. So this particular model, a biopsychosocial model of autism, is a genetic predisposition with environmental and epigenetic factors, with two hit happening in the predisposed individual. That is the current understanding, sir.
I would like to add a point to it. I would like to add a point to it. As of now, what Dr. Lal says is correct. Like, it's a two-hit model, and both of them are not fully elucidated. But what we can advise the pregnant mother is they can have a stress-free period, and maybe some of the infections which can predispose, maybe some of the drugs like valproic acid, all those things can produce some sort of neuroinflammation, and that may be operating in utero and maybe continuing ex vitro. What we do as screeners, we are only trying to identify the symptoms. The process actually starts in utero. So at the current juncture, I think we have to ensure that the pregnant mother is provided adequate support and maybe free of infection. Maybe those things are positives that we should take it out. But as of now, even if you're going to do extensive genomic sequencing, only 10% of the children may fit into that condition. So as of now, things are not very clear. But what is clear is epigenetics will have positive influences on the child. And I think that should be the take-home message. Thank you.
Sir,
Okay, sir.
role of
I think the institutions in Chennai can take up the research, and we have got enough cases. And I think we can get into that. If you go into the details and the exact etiology, we can come with a solution.
There are a lot of challenges again, sir, actually, because even in the genetic findings may change with the races also. A Western thing may not be acceptable for us, actually. So they have come to the chromosome 7 is somewhat related to that, but these are all just a fancy answer for it, actually. As you said, only last month we have got the approval for the genetic testing, actually, through the government. So definitely it will be obeying, as Dr. Uday Kumar sir said, again, the percentage of results may be very minimal, but still it is a long way to go for it, sir, actually.
The gut microbiota has also been suspected, actually. So the gut microbiota through the gut-brain axis. So they cause the brain permeability, and through that the toxic metabolites can travel the brain and cause neuroinflammation. So that is also one of the postulates, and they have also are working on things to improve the gut microbiota so that the gut microbiota changes and these brain permeability things and the vascular leaks things are all prevented, sir. So that is also, there are also thoughts on this as a etiological cause for this autism spectrum and worsening the features of autism.
I think related to gut microbiome, what we also need to understand is a mother's milk is a best. So what we have understood, the first milk that should go into the baby's mouth, even if it is a preterm, I think we can do colostrum swabbing. So that is the one which should enter the baby's gut. And I think, although things are not very clear about microbiome and ASD, but what is clear is breast milk is good. And that should be the first ingredient which the baby should take. And I think that can be the take-home point for the pediatricians.
The basic thing is it is an inflammatory process which is going to alter at the earliest stage, is going to alter everything, sir.
Okay, I think on that note,
We'll
wind up this very interesting session, and so many questions are left unanswered, but only the take-home message is identification, early intervention, counseling parents, don't give them a hopeless outcome. And we know that every child improves with therapy. However severe the autism is, there is an improvement. We know that. So let's do that. And we need more and more people involved in this. I think development pediatrics has got a lot of scope. And if we are able to motivate a few people during this session to take up development pediatrics as a, as a career, I think we have done a good job. Now I hand it over to my colleague, Dr. Uday, and Soms to conduct the rest of the session. Thank you.
Thank you very much, madam, for your for chairing this session and guiding all those panelists to present. And thank you, my dear friends, Dr. Sudhakar and Dr. Lal, for their excellent presentation and their deliberation during this past 1.5 hours. And having crossed the first section, that is on autism, first is the signs and features of autism. The second is the diagnostic part. The third part is the diagnostic and the workup and the management part. We will go on to the second part, that is the mixed bag, which has 3 topics. One is on common neurodevelopmental problems, how to pick it up in the OPD. And the second will be on ADHD, and the third will be on dyslexia. For this to moderate and chair, we have Dr. Uday Kumar. He is a well-known developmental pediatrician and the professor of pediatrics. He is the head Karthikeyan Child Development Unit of Ramachandra, which is the Child Development Unit of Ramachandra Medical College, and he is the IAP Fellowship Coordinator and the MSc Applied Child Development Coordinator. He has done a lot of work in developmental pediatrics. Over to Dr. Uday Kumar to introduce the panel speakers and take over the sessions.
Yeah, thank you, Dr. Somasundaram. And I think so far we have had a discussion from basic to bit advanced level. And the next 3 topics, I think it is more at a basic level. And we have 3 bright speakers who will be talking more on those topics and will be clarifying a lot of problematic areas in these 3 talks. And the first speaker is Dr. Srinivas Raghavan, who is a developmental pediatrician with special interest in developmental neurology and child nutrition. And he has completed his MD from JIPMER, and then he has done his fellowship. He's a gold medalist in that fellowship in developmental behavioral pediatrics, and is currently working as associate professor in CMC Vellore. And he has authored few 30 articles, and he has also co-edited the Scott's Pediatrics book. Over to Dr. Srinivas Raghavan, and he will be talking about how to pick up neurodevelopmental problems in general practice. So it's at a basic level, and his topic is where there is a will, there should be a way. Over to you, Dr. Srinivas Raghavan.
Thank you, sir. Thank you for the kind introduction. I'll be sharing my slides. So, can you see my slides?
Yeah. The slide is visible, and you can go ahead.
Yes, sir. So the topic for today is how is it relevant to the World Autism Day or Autism Awareness Day? When Dr. Somasundaram gave this topic, probably it is to emphasize this point. This is from an article published in the Indian Express yesterday. So the author says that in India, routine pediatric health checks mostly focus on anthropometric parameters, cure for seasonal symptoms, and vaccination schedule. And developmental milestone follow-up is a gap area. And this leads to delay not only in autism diagnosis, but also in other developmental disorders. So whenever we talk to pediatrician about developmental surveillance, the immediate look is this. This is the reaction. This is something close to the reaction we get from the pediatrician. How is it possible at all in a busy office? So today I'm going to talk about how to do a quick and efficient developmental surveillance in a OPD, busy OPD, and how, apart from autism, some more common developmental disorders can be identified by doing a simple protocolized developmental surveillance. What I want to emphasize, I've been saying about this in a few other meetings as well, but this concept should reach us, the concept of dedicated well-child visits. During these visits, apart from vaccination, we also monitor the child's development. And if we link it to the vaccination visits, it will not cause extra visits to the hospital. Even by doing a minimum of 3 visits at 9 months, 18 months, and 24 to 13 months, most of the common neurodevelopmental disorders can be picked up. And how are we going to do it? You start with simple milestone checklists that can be given along with vaccination cards to parents. The parents can fill it up before the pediatrician visit, or in cases where the parents are unable to do, the front office staff can do it. And when they reach the doctor, if the red flags are determined on this milestone checklist, a focus history and examination can be done, and most common developmental disorders can be picked up. All we need is to spend a few more time observing the child in our OPD. These are some common early childhood developmental problems, especially those that can be picked up in the first 3 years of life. So I would be restricting the talk to these things. One is autism spectrum disorder, which presents as language delay, a hearing loss, which can present as a language delay, children with vision impairment, and children with motor delay due to perinatal brain injury, and children with nutritional deficiencies presenting as motor delay. So we'll be seeing how these disorders can be picked up with the help of case vignettes. So what are these dedicated well-child visits? At 9 months visit, you focus on picking up vision, hearing, and motor impairments. And at 18 months, you pick up subtle motor impairments and emerging language and social communication. And at the 24 to 30 month visit, you pick up language and social communication impairments and also early intellectual impairment. So as we can see, just by doing these 3 visits, by focusing on these specific developmental domains, we can pick up many common neurodevelopmental disorders. Until 8 months, the child would be visiting the doctor, the pediatrician, for multiple vaccinations. So what we can do during these times, during the initial few visits, focus on the vision and hearing, the special senses, focus on checking the vision and hearing. Wherever possible, I think it is imperative for us to do a universal newborn hearing screen. Many districts in Tamil Nadu have already done it. I suppose the others also can take up this one. OAE should be done for all children before being discharged from hospital. And where there is any risk factor, a BERA should be done for all these children. So OAE plus or minus BERA in specific situations must be done for all neonates who are getting discharged from hospital. And during the initial vaccine visits, is the child able to track a toy that you are able to give? And while tracking and reaching for the toy, is there any particular hand preference? And you can watch for hand fisting in the child. And does the child have a good social smile when you interact with the child? And does the child startle to loud sounds? Apart from this, the usual routine growth monitoring and head circumference monitoring is mandatory. And if the child hasn't attained head control by 5 months, has the child not showing interest towards toys, and child not turning and localizing sounds, and preferential hand use to reach for toys, and if you notice there is a serially reducing head circumference, or the child is in a microcephaly range and a failure to thrive that is there, definitely these are some red flags where this child has to be monitored closely further. As you can see, a child will be able to voluntarily open and close palms well, definitely by 3 to 4 months of age. Persistent fisting, if you notice the child keeps the thumb closely adducted and fingers curled around it after 4 months, is definitely abnormal. And if the child is persistently reaching out for toy using only one hand, and definitely an early hand preference must make us prompt to examine the other hand. Is there tightness or is there weakness in the other limb that is there? And by moving a bright toy from side to side, as you keep the child on the couch before you vaccinate, you can just move a bright toy from side to side. The child should be able to track well and reach well and able to reach out for it by around 5 months. So initially the child will track well continuously, and then by 4 or 5 months, the child will be able to even reach out for it and grasp it. So this you can do just in 2 minutes before you vaccinate the child. Here is a case vignette. 8-month-old child is brought to you with complaints of not looking at faces. She's not crawling yet. And parents say that whenever she's placed on the couch, she has repetitive head turning and body rocking. When you examine the child, neurologically, the tone is normal. And the child is able to respond to mother's voice by cooing. When mother talks to her, the child responds. The child is responding to tickle by smiling. Now, what is obvious here? There is definitely some vision concerns. When you look at the child play, when you do this tracking of object from one side to other, the child only has a preferential down gaze. The child is not reaching for toys, but the child is attentive to sounds. When you give a rattle, when you shake a sound, child immediately turns and localizes. But when you offer a toy, the child is only trying to search for the toys and pick, and the child is not tracking. So just by doing whether the child is tracking the toy, you're able to pick up vision concerns. And by checking hearing, you're able to find out that the hearing is good. And child has a social smile to mother's interaction, only that the child is not looking at the mother. So we have picked up vision concerns by doing these things. Now, when you go back to history, a focused history reveals that the child was born as a very low birth weight infant, around 1.8 kg. Neonatal hypoglycemia with seizures history is there. So when an MRI was done, this child was picked up to have a hypoglycemic brain injury. So what are we dealing with? This is a child with probable cerebral visual impairment, neonatal hypoglycemia sequelae, and all these children who have had neonatal hypoglycemia, visual stimulation is must. Eye is the window for the world. So any problem with vision, the child cannot understand what is happening around the world. It can result in motor delay. When the child does not see a toy, he need not reach out for it. He may not reach out for it. So will result in poor eye-hand coordination. When the child does not see people, the child does not understand socialization, thereby communication also will be affected. So vision impairment can mimic global development delay, autism, or a learning problem. In CVI, when you check the eye, the fundus is usually normal. So that may not be enough. You should always do a functional visual assessment. How is the child handling a toy? How is the child, when you offer something, how is he using his vision? This should be done, and this can be done clinically. So going ahead, this is the first well child visit, the dedicated well child visit at 9 months. At the 9 months vaccine visit, what should you check? The focus should be on motor impairments and vision and hearing impairments if you have not checked for it in the previous visit. By 9 months, the child should be able to sit by himself and pull to stand by holding onto furniture usually. And the child should have started to babble. And child usually holds up his arms to be picked up. So you're checking for some motor milestone, language milestone, and also some social milestone. These are some symptoms you can ask, or the questions that you can ask. What you can look and do in the office, just wave and talk to the child when the child is seated on the mother's lap. Remember, they say the child will have stranger anxiety. So when he comes into you, he may look at your face intently and he may immediately feel anxious. That is usual. Note that down. And when you wave and talk to the child, when you try to establish the rapport, the child usually gets calm and starts smiling at you. And when the mother cuddles or plays with the child, explore if the child is the child will look at the mother's face well and has a good warm interaction. Then what you should look for at this age, object permanence usually emerges at this age. So you try to hide a toy under a white towel and see if the child is able to remove the towel and uncover the toy. That you can do simply within 1 or 2 minutes. And at the end of all this, you give a raisin to the child by giving us a reward. Is the child able to take up the raisin or karkandu? You can give the sugar crystal. Is the child able to take it out with a good pincer grasp? Observe his grasp. The child should be able to reach out for it with the thumb and the forefinger and take it out. And finally, during your clinical examination on the couch, pull to sit and make the child to stand. Observe for any head lag when pulling to sit and notice if the child is scissoring and standing on toes. The red flags during this visit are having a motor delay, head lag, not able to sit, and scissoring, tone abnormalities in the leg. And also be note this, that if the child is not smiling and interactive and has a poor eye contact during play at this age, definitely it's a red flag. Early social communication starts by this age. And if you remember Dr. Somasundaram's slides, you will notice that the joint attention starts developing by this age. So these are some red flags. You can notice the head lag here, the scissoring here, and the standing on toes here. And here, at this age, the child will be able to sit well unsupported, picking up objects, and child will be able to pivot around from side by side, and child will have a very good warm interaction with the people around with a sustained eye contact, and he'll be using a lot of cooing and babbling by this age. And this is the pincer grasp when he tries to reach out for the object that you're giving. And this is the object permanence. So a child will definitely find the hidden toy by uncovering the towel. So going ahead with the case vignette, this is a 9-month-old boy who is brought for MR vaccination. The child smiles socially and he is cooing. The child has good babbling and he enjoys peekaboo play with the mother. But mother is concerned that he is not yet attained head control and he is not yet attained sitting. Now this is definite red flag that you have picked up just by asking the question. And the child also has had 2 hospitalizations for pneumonia so far. So when you apply the scheme that we have told you, is not attained head control, is not yet turning over, not yet sitting. So we have found out 3 problems. And on examination, when you do a focused examination, you notice the child to be floppy. The child has good stranger awareness. Child doesn't lift the hands yet to be picked up, but he enjoys a peekaboo play. So what you discover further, there is a motor delay, but the social milestones seem to be okay. So probably we are dealing with a child with weakness. The motor delay more ahead than the social communication delay. So this child was picked up to have a predominant motor delay with associated weakness. Eventually, the child went on to get a diagnosis of spinal muscular atrophy. So not only common neurodevelopmental disorders, but some of these disorders presenting a development delay, you will be able to pick up if you do a focused questions, if you ask focused questions and do focused developmental surveillance. Now, this is a 11-month-old girl who presented concerns of not yet sitting. And you notice that the child is short. Her height was only 56 centimeter and the upper segment, lower segment ratio was abnormal for the age. And child had coarse facies and umbilical hernia. So the diagnosis is straightforward. This child was a missed case of congenital hypothyroidism. The TSH was 1662 and the free T4 was very low. And thyroid scan showed agenesis. So this is a child who had congenital hypothyroidism. Again, one more thing that we can all incorporate into our day-to-day practices, doing a universal newborn thyroid screen, which would have picked up this child in early stage and which would have resulted in earlier treatment. The well child visit 2. At 18 months, when the child comes for the booster dose of DPT and OPV, what all we can check for? Milder motor impairments and emerging social communication. And usually at this stage, we should be able to pick up autism. By 18 months or 1.5 years, the child can walk well without support, definitely. The child should be able to fetch familiar toy. If you remember Dr. Somasundaram's talk, he said receptive language. Is the child able to understand our instructions and bring a toy without us having to show it? And thus the child use kinship words appropriately. Amma abdin thirupi repeat pandrathu mattum illa, chittappa abingiradhu repeat pandradhu. He should be able to call out to people. Amma abdin solli he should call out to amma. And does the child copy other people? And what are some things that you can look and do? Call the child by name and observe response. Or you can ask the parents to call out to him when he's engaged in something. Usually by this age, child should have immediately a prompt response. And while the child is coming inside or going out, wave bye-bye to the child and observe the response. Usually children by this age should be able to imitate. They should be able to promptly do it again when you do, or do it in return when you do. And the child should be able to point to at least 5 body parts. You can ask the mother or you yourself can ask and approach the child with the toy closely. You go to the child and try to tickle the child. The child should have a sustained eye contact with you by this age. And if you have a toy that will make a sound, or if you have a toy with which has a key, you play the toy, and once it stops, observe what the child is doing. If the child has good social referencing, the child will take the toy to you or to the parent and will ask them to do it again. Or the child will smile looking at your face and the parent's face. So red flags at this age are the child not talking, no intent to communicate, not even nodding, pointing, waving, having poor eye contact, poor response to name call, and a child who is not walking by now, not even able to stand. All these are definite red flags at this age. So have a picture book at your OPD and see if the child is able to open to picture book and point familiar things to the parent. And when you approach the child, see the child should have a sustained eye contact. Because of some social anxiety, because of some stranger anxiety, the child will be wary of you. The child will continuously look back and forth between you and the parent. Child will turn back, whimper with the mother, and mother will say, "Oh no, doctor, onno say matanga." Like that, child will get convinced. Again, look back at you. So these simple observations of the interaction of the child will be very handy. And look at this video here. So a toy is being played. The child enjoys the toy being played. And the moment the toy is given, child is trying to share the joy with the parent. Now he wants the toy to be played again. What does he do? He can't figure out how. So what is he going to do? A child with good social communication and always seek help. So he's trying to offer the toy to the person around and see, can you do it for me? So this means the social communication is progressing at a typical pace. And in this age group, if you notice the interaction is poor, always evaluate for autism. Now in this video, you will see two children, and observe the video and then we'll talk about it. So when they called out the name, only one child responded. In fact, they were calling out the name of this child, but the other child immediately responded and acknowledged by smiling. And when this child finds some toy interesting, immediately he shows it to the people around. So he has very good social referencing. He's continuously trying to engage the people around him in his play and trying to get their attention. Whereas this child here, from the beginning of this video, if you have noticed, he's only interested in this toy. He's not interested in the social environment around. So if you notice a child who is 18 months of age, who's more interested in the things, and he's not trying to engage with the people around, he's not trying to engage them in his play. He's not trying to share what he likes with the people around. He's not trying to engage the others in his play. He's not trying to look at them. And definitely you should evaluate further for autism. And now going ahead with the case vignette, you have a 1.5-year-old child who approaches to you for not walking without support. They have come for a vaccine visit and parents say, "Inno nadakala." So you have picked up a red flag. And you examine the child, you see the child, he's able to wave bye-bye, he's talking kinship words, and neurologically, there is nothing abnormal. Again, a predominant motor delay with a normal social communication milestone. And when you examine focused, you look that the child has mild wrist widening, but no bowing of legs. And when the vitamin D levels were done, it was 6.2, calcium was normal. X-ray did not show any frank features of rickets, but the child had vitamin D deficiency, and when treated, his motor development picked up. It's associated occupational therapy as well. Remember, rickets is a cause for delayed walking in toddler. Isolated vitamin D deficiency itself can result in motor delay. And in this post-pandemic era, last 2 years, children haven't had much opportunity to go outside, go in the sun and all those. We are likely to see more children with vitamin D deficiency. So we should carefully evaluate for features of vitamin D deficiency in a child who has isolated motor delay. And this is another child, 1.5 child who came for a DPT booster, again, not yet walking. And when you examine, the child has very sparse hair, child has pallor, and also has hyperpigmentation of palms and soles. Now, this child has history of refusal of solids. She is only on biscuits and mother's milk, and on investigation, there was macrocytic anemia with very low vitamin B12. After 2 months of vitamin B12 therapy and nutritional advice, the child smiles, interacts better. She started walking alone and appetite is a lot better. And you can see the changes. The palms and soles have become a lot better now and her anemia improved. So always have treatable causes high in the mind. These are some disorders we should never miss in our primary practice. Now going on to the well child visit 3, between 24 to 30 months when they come to us for optional vaccines, we should always look for emerging language milestone and social milestone and early intellectual impairment. The focus of this visit is going to be on this. By 2 years, the child should be able to talk 2-word phrases. The child should be able to indicate many words verbally. Tanni veno, sapadu veno. All these the child will be able to indicate verbally. A child should run well and child should be mingling well with other children and playing. They should be able to engage themselves in their play and play, not just being along with them. And what are some things you can look and do in this age group? You can ask and give a flying kiss or give a high five to the child. Does the child respond back with a good eye contact? And have some simple toys in your OPD like a cup, saucer, a comb, and see if the child knows the function of this use. This is called as functional object use. And what are some things you can do? Ask the child to jump on 2 feet. You can draw a line in your OPD and see if you're able to jump. In the line, or if you have a small step, you can ask him to jump from step 1. And give a paper and crayon to the child when you talk to the parents and see if the child is able to copy a line or a circular scribble that and see how the child is holding the crayon at this age. And by 2 years, 2.5 years, they should be able to label at least one color. They'll be able to name one color. Nee enna color setup potrukka, idu enna color, like that you can ask. And child, if you have 2-3 balls in your OPD, you can ask idila edu romba perus ball, idila edu romba kutti ball sollu paakala, like that you can ask. Child will be able to identify biggest and smallest of a group by this age. So just 4-5 things which you can finish within 1 minute. Not saying any words, not using words purposively, not indicating needs verbally, not even trying to get attention of others, not mingling with peers, and difficulty in running and waddling gait. Remember, children with Duchenne's muscular dystrophy would have had delayed walking, but by this stage, they will have a deterioration in their walking. They may start having toe walking, and they may have frequent falls while walking and all those. So you can pick up children with these problems in this visit. So this is functional objectives. They know what is a phone about. When they see a receiver-like object, they'll take and say hello. And when you give a comb, the child will try to comb himself. This will lead on to simple pretend play and role play games in the future. And I said about the grasp. When you give a crayon, look at how this child holds and compare this with this child. Here, the child is trying to hold with the palm, whereas here, the child is trying to hold with the fingers. So the grasp emerges as the child ages on. Initially, it will be a cylindrical grasp by 1.5 years. By 2 years, it becomes a pronated digital grasp. The hand is pronated and the child holds with the tips of fingers, but still the tripod grasp hasn't emerged. By 3.5 years, the child will hold with 3 fingers, the tips of 3 fingers. And the mature grasp that we all have will emerge only after 4.5 years. So just by giving paper and pencil and seeing how the child holds, we can see if the fine motor development has proceeded in the usual pace. Again, to focus on autism, in a toddler with speech delay, if the child is avoiding eye contact, not even using gestures, not mingling with others, not sharing his interests, and if the child has peculiar repetitive body movements in your OPD, if he's excited, he's flapping around, continuously running around, not responding to name call, always suspect autism. And you can do a simple 3-item direct observation screen. This is called as the TIDOS method, where first thing is call the name of the child, observe for response. Point to an object at a distance. You can have something across your table. And the bommai paru, like that if you point, or you can ask the mother to point. Does the child follow you? As the joint attention develop, you can check. And finally, quality of eye contact during interaction. Only 3 items. Name call response, pointing to an object and seeing the response, and quality of eye contact. These 3 things will help you. Score 0 indicates low risk. Even if you don't have time for an MChat, this could be a simple screener. Then you could call the parents further again on another day to do a MChat. A 2-year-old boy came for DPT vaccination. Mother says, "Romba thuruthurunu irukkan doctor, innu pesa maatengran, edunalum aludhu therivikaran." And father immediately cuts off the mother, saying, "Nanu late dhaan pesana doctor, avan vayas kulandha mari avan vandu velata dhaan irukane thavara vera onnu thondru illa." That's the response. Now, when we use this structured observation, child does not respond to name call. But when a pen falls, he immediately turns to look. When the doorbell rings or when the doctor presses the bell, he immediately responds. So no problem with hearing. Does not wave bye-bye, high-five when prompted. He continuously goes around the room, opens the tap, picks up toys, climbs on couch. But when you give a toy stethoscope or a doll, no pretend play yet. He does not share his interest, and the room la paakradala unga parents kitta share pannala. So definitely there is speech delay with poor interaction as well. This child would need an assessment for autism. And this was already told, not all hyperactivity is ADHD. Dr. Somasundram said this. ADHD is usually seen in school age group children. These children will usually frequently disturb people and they cannot wait for their turn, and they are often viewed as talkative. But when you see a toddler, when you see a child who's around 1.5 to 3 years of age who is hyperactive, you should always think of autism before you think of ADHD. Children with autism tend to be aloof. They are preoccupied by peculiar interests, and always they never bother about the people in the room, and they only have a need-based, limited interaction with people. So these points will help you differentiate autism from ADHD. Not all hyperactivity is. So once you suspect developmental delay, what more should we do? So this we should always remember. describe to the parents the concern. Sorry?
I think someone needs to unmute, I think.
Yes, sir. So once you suspect a developmental delay, describe to the parents the concerns. Explain unexpected typical development. You should say, by this age, your child should be doing all this, but I am noticing that he's not able to do. So you tell them what is typical development and tell your observations of the child, and never sugarcoat the truth, fearing losing a client, because for us, we should be an advocate for the child. What the parents may think, all those, definitely you should tell, I have these concerns. Please go back, observe your child. If you also feel it is true, come back to me. Let us talk about it. So that is the first visit thing that you have to tell them. Never sugarcoat the truth, fearing losing a client. And then second important thing I wanted to say is practice non-judgmental terms. It is always good to use words such as typical development, atypical development, rather than using the term normal. We are so used to using the word normal that sometimes we inadvertently use it, but once we practice this, we can avoid it, because normal can have a lot of implication in the minds of the parent. And when they perceive their child as not being normal, they carry on a lifelong guilt. This is the reason for stigma in many neurodevelopmental disorders. So practice non-judgmental terms. And next thing, never make parents feel responsible. நீங்க டிவி காமிச்சதுனால தான் இது மாதிரி ஆயிட்டான், all those. So never make such passing judgment, because the parent can again carry on the lifelong guilt. And explain to the parents that early intervention best results, so do not delay in taking your child for treatment. And refer appropriately for the early intervention. No unnecessary wait and watch. 2 மாசம் கழிச்சு பார்ப்போம், like that. Let them start on intervention. Let it be nothing, but just provide the appropriate guidance and follow up the child. And always direct parents to good information sources. As much as internet is loaded with information, it is also loaded with a lot of misinformation. So it is our responsibility to protect our parents from misinformation. And how therapy helps the child. Again, this is something, this notion we have to change. Previously, people think that any neurological disorder or neurodevelopment disorder, nothing can be done for the child. இந்த குழந்தை விட்டு நீங்க அடுத்த குழந்தை பத்தி யோசிக்கோங்கம்மா, there is nothing that can be done for the child. That was the word that was said to many parents a few years back. But there has been a paradigm shift in the way we look at neurodevelopmental disorders. We have so far been viewing neurodevelopmental disorders from a medical model. That's why parents seek cure, which is not attainable. இதுக்கு எதுவும் வைத்தியம் இருக்கா, இதுக்கு எதுவும் குணப்படுத்த முடியுமா அப்படின்னா, the truthful answer is no. But that does not mean nothing can be done for the parent. We have to help parents realize that there is a biopsychosocial construct to disability. And definitely we can bring about a functionally optimal outcomes to these children. So as primary care pediatrician, we all have the family's trust. The family seek and cherish our appropriate guidance and words of motivation and follow. So educate yourself, be in touch with the intervention team, periodically discuss the child's gains and present goals, and praise the parents for doing this, and instill hope for these children. And whenever possible, provide separate appointments for some children. Dr. Lal said, make your OPD as autism friendly as possible. When you have a child who cannot wait in a crowd, provide separate appointments for them, so that you can also support inclusion and you can also support these parents. The parents will definitely cherish this. So I'd like to conclude by saying these take-home messages. Picking up concerns early, 3 well-child visits tied to vaccination visits is very much doable. Where there is a will, there is a way. Provide correct guidance, explain the concerns, guide them to early intervention, and often give hope. Functionally optimal outcomes are possible with early appropriate intervention. And some treatable causes that we should not miss at primary care level is hearing loss. Always practice universal newborn hearing screening. Please implement it wherever possible. Look for vision impairment in early childhood. Hypothyroidism, please do a universal newborn thyroid screening wherever possible. And when clinically indicated, do TFTs. Nutritional causes, iron deficiency, vitamin D deficiency, B12 deficiency must not be missed at a primary care level. So you started this presentation with this look. And throughout the look, when I started talking, you said, Vidamatam pola irukku, seri gavanichudam paapom அப்படினு. You must have had this look. But at the end of this talk, if you at least are interested, or ஏதோ இருக்கு, ஏதோ நம்ம பண்ணலாம் போல இருக்கு, if you have come to this look, and I'm happy. Thank you for the opportunity and your patience. And this is from our team at CMC Vellore. This was at the World Autism Awareness Day. I bring wishes from the team CMC Developmental Pediatrics. Thank you for the opportunity.
That's a wonderful and practical talk, Dr. Srinivasan. Actually, you have taken through case scenarios at various age groups. And I think practitioners, if they are going to follow all these basic techniques, like particularly attending to parental concerns in the early stages, and I think that will make a big difference. And if your clinic is busy, what I would suggest is you can engage your receptionist or any nursing personnel to have a screener, like say TDSC or some of the online screeners like Track and Act, which is a free app from ThoughtGate. So those sort of apps can be used, and if it generates some results, I think you can focus more time separately as a first case or as a last case. And then you can do a lot of things for these children, and you can even make a big difference in the child's life by providing early intervention. That's a very good talk, Dr. Srinivasan. And we'll be moving on to the next talk. We always see in our clinic, like some children will be overactive, and we have a doubt like whether this child will have ADHD. And to clarify on that, we have Dr. Venkateswaran, who is a child and adolescent psychiatrist, practicing at KKCTH Mehta Hospital and Children's Hospital, Apollo, Chennai. And he finished his MD Psychiatry from Coimbatore and fellowship in child and adolescent psychiatry from CMC Vellore. He has worked as AP in CMC Vellore, and he has quite a few publications, and he has chaptered and written review articles. Over to you, Dr. Venkateswaran, on this topic.
Thank you, sir. Thank you for the kind introduction. I like to thank Dr. Somasundram and IAP for this good opportunity. So today, like after all beautiful and exhaustive presentation, I like to keep it simple on ADHD. Okay. So this is one of the common neurodevelopmental disorders. So as you all know, it is a neurodevelopmental disorder, and core symptoms include hyperactivity and inattention. This prevalence this is the most optimistic prevalence. Okay, 6.5% from various literature, but I feel like it is much more than 6.5%. Okay, in a school, in a class, if you go, you can easily pick up 2 to 3 children with ADHD symptoms. Okay, they may be in a severe or they may be in a mild range, but you could easily pick up easily 2 or 3 children in a class. Okay, and if you see the disease burden, 65% persists into adulthood.
Switch off your video and present, sir. So,
pardon, sir.
You can switch off your video, sir.
Your net connection is a bit unstable. I think maybe you can switch off video and talk. I think that's what someone wants to tell.
1 second, sir. Give me a second.
Maybe if the connection is fine, you can go ahead.
Yes, sir. Like 1 second. Give me a second, sir. Give me a second.
Yeah, it's now fine. You can go ahead.
Yeah. So if you see the disease burden in adulthood, no, it is okay, sir. Is it fine?
Yeah. It's
fine.
Yeah. So 65% persist into adulthood. But if you see the adult prevalence, you see it is 2.5 to 3.4%. It is much less. So what is happening? Is the ADHD vanishing? No. This is a changing nature of the symptoms, which we will be seeing in the slides to come. So this is the DSM-5 criteria for ADHD, 6 out of 9 in hyperactivity, impulsivity, or inattention. I'm not going to read out each and every criteria. So I'm going to give ICD-11 criteria. So this ICD-11, they have given operational definition for all the core symptoms. Okay. So what is inattention? Inattention is defined as difficulty in sustaining tasks that do not provide adequate stimulation or rewards. Okay, many times like parents used to ask, my child is able to sit and watch TV for 45 minutes, 1 hour. Then how are you saying it? It is inattention. Okay, again, that is why ICD-11 has clearly clarified the inattention is only for cognitively demanding tasks and not for tasks which gives adequate stimulation. And for the first time, the ICD-11 has brought this poor organization, because as children with ADHD grows, the core symptoms diminishes, and they will have more and more of executive dysfunction. They will have poor planning, poor problem solving, poor organization. Okay, so now they have brought in the inattention domain. Okay, the executive function is affected. Second, hyperactivity. Hyperactivity is excessive motoric hyperactivity, which usually you will see in the toddler and preschool age group, and most evident in structured situations. Okay, so that is why DSM-5 says, like, usually wait for diagnosis of ADHD till 4 years, unless till they go for all the structured situations like school or a play group where they are supposed to sit in a place and they are not able to sit. Okay, so this is hyperactivity. In impulsivity is tendency to respond immediately without any deliberation or consideration. Okay, this we will see more and more in the older children and adolescents. They quickly react. Okay, if you see the progress of these symptoms, motoric hyperactivity, as I said, it will be there in the preschool children. When this is missed, sometimes people brush aside, like as previous speakers told, நார்மலா தான் விளையாடுறான், மற்ற குழந்தைங்க மாதிரி கொஞ்சம் சுட்டியா இருக்கான். When this motoric hyperactivity is missed, as the child grows, this motoric hyperactivity will be reduced by itself and you will not be able to pick it up. So when the child come for well baby visit or the pediatric office visit for any other illness, the child is all over the place, running, jumping, climbing on the table, picking up things, switch from one thing to another. The easiest way to differentiate from autism is usually the children with autism who has stereotypes, running to and fro or flapping and running. They won't disturb anyone. Okay, ADHD kind of hyperactivity, it will be like you will be on the toes safeguarding all your valuables. You will be safeguarding your ophthalmoscope or valuable materials. So they will be all over the place and picking up everything. So switches from one thing to another. So this motor hyperactivity is common, very common in preschool. As the child grows, you will start seeing inattention. Inattention is very difficult to elicit from a preschool. Okay, so they will be participating in a play school. They will be participating in the rhymes. Rhymes usually comes under a stimulating task. So when they sing rhymes for 5 minutes, 10 minutes, the child will be able to focus. So when you even ask a play school teacher, rhymes la nalla pandrane, drawing, if it is stimulating for the child, they will be able to sit. But as the academic demands increases and when the child is expected to focus for a longer hour, then only the inattention sets in, school age children. So it usually presents as gradual academic deterioration. So nalla படிச்சிட்டு இருந்தான் first standard, second standard, then the academic starts deteriorating. Naturally will screen for LD, but the ADHD inattention presents like this. And once they go into adolescence, they usually have inattention as well as all these executive functions. Poor in controlling impulses, poor in regulating emotions, poor planning, poor problem solving. These symptoms will more present as a social skills issue, interpersonal problem or behavior problems. They usually bring the adolescents for unrelated behavior. But when you go into each of these symptoms domain, they might be having ADHD. It is the changing nature of the symptoms rather than any new neuropsychiatric issue at that time. And in that age, older children and adolescents, the core symptoms will usually manifest as unfocused mental activity, not able to focus on one thing, not listening to conversation, especially in the class, and very subjective restlessness. Like the child will be like fidgetive, but you won't see that motoric hyperactivity. So this is how ADHD hyperactivity, inattention, and impulsivity presents through the age. And people will think he was hyperactive, but he got cured. No, he has not cured. The symptoms nature changing over the developmental ages. So here I have given comorbids. Okay, previously we used to discuss as differential diagnosis. So the more than telling as a differential diagnosis, I use the term comorbids because till 2014, where we cannot diagnose autism and ADHD in the same children before the advent of DSM-5, like there was a huge discussion among professional community whether it is autism or ADHD, whether it is autism or ADHD, even between therapists and the doctors, between therapists, between doctors, like we had this meaningless discussion. But now this ADHD is highly comorbid with these conditions. If you see, as they grow up to 80%, they can have this conduct or personality disorder. They have huge interpersonal issues. They have behavioral issues. They will not be able to adjust with office, personal life, and family life. So this is highly comorbid. And ASD and ADHD, many times this high functioning ASD, they invariably have ADHD symptoms. Okay, we call it as optimal outcome. When the autism children like between 2 to 5 years, they improve in terms of IQ, normal IQ. They don't have any more stereotypes, and the verbal expressive speech is as appropriate to the age. We call it as optimal outcome. This children with ASD who has had an optimal outcome, the independent living is possible. Okay, these children invariably they have ADD or ADHD, attention deficit disorder or attention deficit hyperactivity disorder. And it is usually, once a child has a diagnosis of autism before, we should not miss ADHD because it has a long-term neuropsychiatric morbidity. If you see substance use and anxiety disorder, up to 40% and 25% when they grow up. And there is no clear data on these things. Okay, psychosis, schizophrenia like psychosis, bipolar affective disorder, intellectual development disorder, all these things, how much it is comorbid with ADHD, we do not have clear-cut data. But ADHD is a condition which has very high comorbidity ratio, and only if we treat all this comorbid condition, we will be able to give a meaningful treatment to the children with ADHD. So these are the routine management protocol as per AACAP, American Academy of Child and Adolescent Psychiatry. Will go into individual thing. Okay, this slide is important. So once you have a child with suspected ADHD, so we have to bring out these information. Okay, antenatal and perinatal outcomes. Is there any significant history? Is there any problem in other developmental domains like speech or signs of autism or signs of LD? And acquired causes of ADHD or ADHD-like conditions. Sometimes CNS infections can present with hyperactivity. ENT infection can present as inattention. Sleep disturbance. Children with poor sleep can present with restlessness, which can mimic hyperactivity. Obesity leading to obstructive apnea can present as hyperactivity and ADHD-like symptoms. The next 4 is ADHD mimics and the antenatal development dysmorphic features. Why it is important? Having said that, previously we had a discussion on what are the genetic outcomes of genetic causes of autism. So I like to slightly off track here, because ADHD and autism share so many common genetic parameters. This history is very important because nowadays many children who has had developmental disorders in the first child, they come and ask us whether when I'm going to plan for a second child, whether my child can have same symptoms, whether my child can have this condition. So now, as a protocol, whenever there is a child with neurodevelopmental disorder, autism or ADHD, we have to screen for we have to go for a prenatal counseling. So what are we doing? Here, I want to slightly touch on genetics of ASD and ADHD, which commonly share so many things. There are 3 genetic possibilities. One is chromosomal disorders like 21 trisomy. Next is single gene disorder, very known single gene disorder like FMR1, MECP2 mutation, which are very straightforward. These 2 things we will not miss because these children has a characteristic dysmorphic features, other organ anomalies, classic clinical presentation. We usually will not miss. Okay, these disorders will not be missed. But what is adding complexity here is complex genetic disorders. Example, there are so many COMP number variation, single nucleotide polymorphism. These are the things which can present as neurodevelopment disorder. So what are these things? These are the sometimes normal variant present in the general population. For some children can present as these developmental disorder. Why normal variant present as developmental disorder in some people? This is where, as the previous speakers told, the second hit hypothesis. The second hit can be epigenetics. The second hit can be another genetic, smaller genetic problem. The second genetic can be microenvironment like PAH, DDM, or IUGR, or a birth asphyxia. This second hit can be very poor stimulation after birth. There are so many, and gender. Okay, they say mother can be carrier because the female gender is protective, and the same copy number variation in the child can present as one of the neurodevelopmental disorder. Okay, so the second hit can be anything under the sun. If we could find the solution for the second hit, then we are towards cracking the etiology of all these neurodevelopmental disorders. So as a prenatal counseling, we are encouraging the children to get tests for micro RICG or whole exome sequencing if possible, and try to find out is there any carrier state in parents, and providing genetic counseling with association with some of the well-known genetic centers in the city. So we are already doing lots of work in this regard. So once you have a children with any neurodevelopmental disorder, a detailed antenatal perinatal history to pick up any environmental reasons, microenvironmental reasons, any dysmorphic features to find out any classical genetic disorder. The couple is planning for the second child, definitely they have to guide it for the proper genetic testing and give them what is the risk factor for the second child to have these neurodevelopmental condition. Again, as per American Academy of Pediatrics, routine EEG, MRI, or TFT is not required, but on clinical suspicion, when the child has multiple seizures or absence like picture, or a past head injury, significant head injury, or keep mouthing things where you suspect lead functioning or other signs of thyrotoxicosis, then please go ahead and do these relevant investigations on clinical suspicion as a part of ADHD workup. Again, routine psychological testing is not mandatory as per AACAP, but most often we end up doing one of these psychometry, especially the LD is highly comorbid. I did not give LD because invariably the LD is comorbid with ADHD. Okay, invariably we end up finding one or other signs of LD in 70-80% of the children with ADHD. I'm talking about specific learning disability. They will have one or other reversal, poor reading, or poor comprehension, or poor handwriting. All these things are very common in ADHD. So we invariably end up doing IQ assessments, and we commonly use Niemann's battery for specific learning disability assessment. And once we find comorbid LD, the treatment should be for both LD and ADHD. Again, especially the neuropsychiatric assessment is very important. Once you treat ADHD, if there is no clear-cut improvement in symptoms, especially in 1 to 2 months of treatment, always look for comorbids. So treatment, okay. So what is sensory integration? So treatment we'll divide into pharmacological and non-pharmacological. I will slightly give an overview on non-pharmacological treatment first before going into a pharmacological treatment. Okay, the sensory integration is the most commonly practiced treatment, especially in city. So based on Jean Ayer's principle of sensory integration done by occupation therapist, what is the level of evidence? It is grade C. Okay. So what they do, the occupation therapist define this hyperactivity as the outcome of proprioceptive seeking. That is, they have more joint position. Okay, the position of joint, that is proprioceptive sensation. These child more and more seek this sensation, as well as vestibular sensation. So by doing some compression, therapeutic warming, the children calm down and hyperactivity improves. So is there any controversy? Yes. What does American Academy of Pediatrics say? They have given separate guidelines for this sensory-based therapy in 2012. Sometimes I have seen people diagnosing a sensory processing disorder. As per American Academy of Pediatrics, the clinicians, the therapists, I'm not talking about therapists here, clinicians should not diagnose sensory processing disorder as a separate category. Whatever the sensory problem, it should be part of other developmental disorder. Inform parents about lack of evidence of the sensory-based therapies. Yes, clinically we see improvements with sensory-based therapies, but we should have a duty to inform parents. This is currently evidence-based because not much good quality evidence has accumulated to support regular practice of sensory-based therapies. Clinically, we see improvement. I agree with other clinicians. Clearly, keep a timeline. Okay, we'll keep 3 to 6 months. We'll start sensory-based therapies. If the child improve objectively in some of these outcomes, for example, in ADHD, we expect with sensory-based therapy, the child should improve in terms of gross motoric hyperactivity. The child should be calm. In turn, the attention should improve. If you are practicing sensory-based therapy for autism, so what I expect, the child should improve in terms of stereotypes, hyperactivity, and the child's general behavior level should come down. So clearly set an objective and start a therapy program and see whether by how can we set an objective. We can have a behavior diary, and where every week the parents can give a color code about based on the nature of the improvement, and review at the end of 3 to 6 months and see if therapy is working. As of now, none of the AAP guidelines or AACAP, they don't recommend sensory integration in the treatment of ADHD, but clinically we practice, but it should be the objectively measured rather than practicing without any check. Next is environmental modification. This doesn't have much evidence, but it doesn't require any evidence because it is very simple and effective. We are not going to break our head in practicing. So how to modify environment in school and home, so that the child will get the benefit. This is simply counseling the parent over a session or two, and writing a letter to the teacher will help to improve the environment of children with ADHD. In school, in home, introduce structure to the child. The physical environment should have visual reminders and distraction. When they study, the table should be distraction free. Use clear highlighters for important points so that they'll be able to focus better. Don't make them sit for hours together. Give them 20-25 minute session. Give a break, preferably a physical break in between, so that they come and focus better. And ways to channelize energy, like by putting them in sports or dance, etc., so that like they get that calming effect. Okay, once they have this structured routine and proper, less distraction free environment and physical activity, they will improve in terms of hyperactivity and inattention. School, naturally seating near teacher and with near a less intrusive child. Break the instruction into small parts. More time to be spent on this child, and again the teacher can give breaks. Nowadays some teachers are giving breaks for entire class. After 15-20 minutes they ask the class to go for a jump and come back. Okay, so this is very healthy practice. So once they modify these things in the school, again the children will have the children with ADHD will have benefits. Okay, the environmental modification as of now doesn't have much evidence, but we don't need evidence for such a small and healthy practices. Behavior therapy is the most evidence-based pharmacotherapy. It is the first choice for preschoolers with ADHD. Okay, preschoolers with ADHD, and sometimes it is used as adjunct to medications for children with ADHD. Okay, again here what is happening is it should be a parent-teacher mediated program. Okay, many a time I see centers practicing behavior therapy by taking the child alone to the room. So that is basically cognitive therapy. They teach them some cognitive skills or adaptive skills using behavioral method. That is not behavioral therapy. Okay, what they do is cognitive therapy. The behavior therapy is basically guiding parents and teachers regarding these. I'm not going to go into each and everything. So guiding parents and teachers on these principles of behavior management, so that the behavior can be managed successfully in the environment, like that is home and school. So it is parent and teacher guided behavior therapy, which has a category A evidence, which is the highest form of evidence. Now many meta-analyses are there supporting behavior therapy for ADHD. In fact, IJP recently has given some guidelines on behavior therapy of ADHD, 10 to 20 sessions. It's an 8 to 10 week program. And this components, they have given components as well as for this parent-mediated and teacher-mediated behavior therapy for children with ADHD. And CBT, cognitive behavior therapy for ADHD. Again, this is mostly for older children and adolescents. As I was telling, as the child grows up, from motoric hyperactivity to inattention, they will start developing lots of executive dysfunction, leading to interpersonal deficits and other neuropsychiatric morbidity like depression, anxiety, etc. So the cognitive behavior therapy should focus on these executive dysfunction, like improving social skills, improving time management in their studies, problem solving skills, having taking lesson from the previous problematic situation and applying. Okay, teach them to apply how you dealt with the problem because of your behavior, because of the child's behavior, how to apply in the future to deal with the same problem. Expressing feelings in a much better way, self-control, anger management, all these things are part of. I just give a brief overview of what all being practiced in cognitive behavior therapy, but this is the mostly therapy of choice in adolescents and adults with background ADHD who will predominantly have executive dysfunctions. Okay, because without addressing executive dysfunctions, the treatment of ADHD is incomplete, especially in older children and adolescents. Cognitive training, it has a great C evidence like sensory integration, but again, we did not break our head to implement. It is a very simple. We can encourage children to either a therapist mediated or parent mediated to involve them in a simple cognitive task where they focus so that their attention improves over time. Okay, this is cognitive training. So this is regarding non-pharmacological treatment available for ADHD. I'll just throw a light on pharmacotherapy briefly before completing my presentation. So again, all the guidelines, you take any guidelines in the world, the pharmacotherapy for school age children and adolescents with ADHD, it's a level A. Okay, this is a first line therapy for first line treatment of ADHD, school age children and adolescents. And we follow something called modified Texas algorithm for choosing the medications for ADHD. Most underutilized therapy because of the stigma associated with that. Here is where like we require support from pediatricians all over, because when I write medications, even developmental pediatrician, when they write medication, they end up with a treating pediatrician telling doctor the medicine kudutharu, is it okay? Like probably if you also support us, like okay, reinforce them. This is the ADHD. They have evaluated, diagnosed, and this is the treatment as per guidelines. If you could support us in that, the child will definitely benefit from pharmacotherapy on ADHD. Otherwise, invariably, they end up discontinuing medications and they will have long-term morbidity. So, I'm not going to go into algorithm. Usually, first line is methylphenidate, osmotic release, long-acting preparation. Second line is again stimulant. Why I say methylphenidate? Because it is available in India. Second line is also stimulant, a different preparation compared to first line. Third line is atomoxetine, bupropion or tricyclic antidepressant or alpha agonist. It is a fourth, fifth, and sixth. But we usually don't practice regularly. We either stick with methylphenidate or atomoxetine as a treatment of ADHD unless the child has comorbidity. So I'm sure you all know about these things. For the time, I am skipping all the dose and the side effects. These are the common side effects: decrease in appetite, weight loss, insomnia, headache, sticks for stimulants. And GI side effects and decreased appetite is common for atomoxetine. This is very important. So we have decided to start on pharmacotherapy recently. So much evidence has accumulated that pharmacotherapy has definitely a long-term say in terms of interpersonal issues and social functioning in children with ADHD, occupational functioning. They have a better occupational outcome and better sustenance of jobs, and they have a better academic outcome. Mortality, okay, there are so many children with ADHD, when they grow up, they end up with road traffic accidents. Recently, more and more evidence are accumulating. By treating ADHD, the road traffic accidents are prevented. Comorbids like neuropsychiatric comorbidity, definitely there are lots of evidence accumulating. By treating ADHD early, we can actually prevent lots of substance abuse in the long run. Okay, definitely the treating ADHD early can prevent long-term social, occupational, and comorbidity. There are lots of children, especially comorbid ADHD and autism, they have a higher rate of neuropsychiatric comorbidity because this neurochemical imbalance, when it is addressed early, we can definitely prevent the poor compensatory mechanism from the brain and have a meaningful reduction in comorbidity. So if we miss that early treatment of ADHD, definitely these children are at a higher risk for lots of neuropsychiatric comorbidity. So it is nowadays clearly all the guidelines point towards treating ADHD early rather than waiting for something. Okay, thank you.
That's a wonderful talk, Venkateshwaran. Actually, you covered everything. Like you talked about the core symptoms, then you talked about how the presentation varies. I think that should be a very practical point for general pediatricians. Like initially, hyperactivity will become more like inattention, and then maybe executive function deficits will all add up. The other important point is comorbidities. I think that is a very important point which everybody should take note of it, because it's something like 50 to 70%, and we have to focus more on that. And another important point is whatever we are seeing in terms of ADHD symptoms, it's only the tip of the iceberg. What is submerged beneath that 7-8 will be academic problems, occupational functioning, maybe peer relationship, low self-esteem, accident prone, all those things, I think we need to look at it, not only at the symptoms of ADHD. A very good presentation, Venkateshwaran. And now I think we'll take questions at the end if at all it is coming. And thank you, Venkateshwaran.
Thank you, sir. Thank you.
Next speaker is Dr. Somasundaram. I think he's been the star for the show and he's the coordinator for the whole program. And I think he's going to take us through how to pick up dyslexia in our day-to-day practice. Over to you, Soms.
Yeah, thank you, sir. I know we have shoot up the time, but anyway, for the purpose of completion of all the neurodevelopmental problems, and I'm happy that we had a good deliberation and we are covered all the common neurodevelopmental problems, excluding this cerebral palsy and motor disorders. So the last topic of the day, I will try to cover it in within 15 to 20 minutes and brush you up on your memory of dyslexia. So this dyslexia, the poor school performance. So nowadays, not nowadays, for the past 2 or 3 years, I have come across many parents occasionally after the school has started now. So coming and saying that the child is not, the books are coming empty, the child is not able to concentrate in the classroom. When I say also the child is trying to forget and those things. So that we will go through, brush up the 2 or 3 case scenarios. This is a 7-year-old child, only child of a middle class educated parent studying 3rd grade in a CBSE school, developmentally normal except that his language milestones were delayed. Not performing well in writing and repeating in accordance with his peers, notebooks returned home half empty, otherwise calm and friendly, investigations were done. Observant grandmother gave the clue that Haran is using the right ear to talk in the mobile phone. A hearing evaluation done at 7 years revealed that he has got a sensory neural hearing loss in the left ear. So this is a medical illness. So causes a medical illness which has caused a hearing impairment. This is the case 2, 8-year-old Dadan, one of the twins studying 3rd grade in a metric school in the same section, decreased academic performance compared to the other twin, has the tendency to disturb others in the class, moves from bench to bench. His mom has to get him a new eraser and a pencil often since they get missed in the school. Poor handwriting, mom finds he often misses a letter in words while writing and reverses Q for P and such on. Mom has tough time making him sit and finish his homework, has difficulty falling asleep also. So this is a case of a neurobehavioral problem. So this child has got specific learning disability with ADHD. The last case scenario is a 13-year-old Raman. So the first child, 5 to 6 years of age. The second is an 8 to 10 year in the middle school. Now it is a higher secondary school or high school. Only child of a businessman, studying 9th grade in a CBSE school, performing below average in all the classes. Since the school has no detention policy till 8th grade, he was promoted. Now not interested in going to classes, picks up quarrel with the parents. Adolescent physician counsel, IQ revealed 69. So this is a pure case of intellectual disability. So as volume of studies increases in higher classes, children with mild intellectual disability may not be able to cope up with it and get at this time only it get revealed. So the magnitude of the problem, the poor school performance as such, poor school performance is obviously getting low marks in the school. In Indian children is between the 5 to 8 years is 10.23%. In that, the learning disability is about 9.6%. And the beauty part is that 52% of the school teachers have poor knowledge and identification of the learning disability because they are the first exposure to these children and they need to identify this learning disability. So presentation in school backwardness can be a failure in examination, not writing down notes in the class, forgetfulness, not concentrating in the studies, reluctance to go to the school, behavioral problems, and finally they bring out multiple physical symptoms. One day to avoid going to school, they say headache, the second day stomach pain, then the third day they have other things like, and whatever they say the eye pain or something like, and they avoid the school. So the ill effects of poor school performance, school is the basic thing. If they don't go to the school, they have a negative impact on the emotional and the social well-being. Usually they are branded as lazy. So they will not be able to complete the school. Higher education will not be completed. Employment will not be there. So finally, marriage cannot be done. So causes for the poor school performance. So before going to the proper dyslexia, I'll say what are the causes. So these 4 are the prime causes for school performance. Whatever may be,
the problem should be in the child, or the problem should be in the family, or the problem should be in the school, or the problem should be in the environment where the child is there. So I will say 4 major headings under which the child factors lie. The first factor is the medical problem. The second is the neurobehavioral problem. The third is the intellectual disability, and fourth is the emotional. So intellectual disability, everyone knows. Emotional factors also we know. Medical causes, first comes the malnutrition. Without a nutrition, the child cannot learn. The brain's nutrition is the breakfast. Most children are skipping the breakfast. So without a breakfast, the child cannot have a proper education in the school in the morning hours, proper learning in the school hours. So malnutrition and acute malnutrition, a chronic malnutrition, a visual impairment, a hearing impairment, which I have already shown, hypothyroidism, which Dr. Srinivasa Raghavan has already elaborated, epilepsy, chronic asthma, diabetic mellitus, various anemias, and major other conditions. So this medical factors has to be thought of when a child is presenting with poor school performance. Hearing, as I mentioned, sensory neural hearing loss or acquired conductive hearing loss should be thought of. Refractive error, strabismus, astigmatism, all are causes. So coming to the neurobehavioral, think of only 3 or 4 conditions: specific learning disability, ADHD, a high functioning ASD, or a Gillet-Tourette syndrome, and so on. But have in mind the first 3, the specific learning disability, which I am going to elaborate, the ADHD and ASD. Coming to the home factors. So we have seen the child factors. What are the factors in the children? Either a medical factor or an IQ factor or a neurobehavioral factor. Coming to the home factor, probably the poor education of the parents, the poverty in the family, a poor motivation from the parents, or the child has to do a lot of household work. So these are also the other factors in the home. School factors, probably the frequent change of school or the curriculum. The probably parent may need to get transferred from place to place, or they may not be able to afford in the CBSE curriculum, so they change to the matriculation or the government curriculum. Being bullied in the school, the child may not be performing, so the other children may be bullying the child. Not getting connected with the school environment, competing demands on time, disliked by other students and teachers. So this is the third prime factor, the school factor. Environmental factors, excessive media viewing. Now that has become a major factor. Poor sleep, very, very important. Only when you sleep, your neurons get interconnected, your neurons get activated, and your memory gets reinforced. So sleep and nutrition, breakfast and night sleep, they are very, very important factors for a child to get a proper education. So having seen 4 factors, we find that the child factor is very important. And among the child factor, the neurobehavioral factor, the learning disability, is 9.6% in the general population. So we need to find out what is this. Try to read the following. Example 1. Try to read this. According to research. So this is the way a dyslexic child will be able to see the text. How will they able to see this, and how will they able to find out what is there in the text and learn that? So the core deficit is the phonological awareness. So the phonological awareness is not there. So a disorder in one or more of the basic psychological process involved in understanding or using spoken or written language, which may manifest itself in an imperfect ability to either to listen or think or speak or write, spell, or do calculation. All these areas, any one of these areas, the child may be lacking in able to perform. So that is the dyslexia. As I already told you, the incidence of dyslexia in school children, again, like as we found for autism, again, this is very, very, very higher, 5.3 to 11.8%. Indian children, 9.8% is the incidence of dyslexia. So 1 in 10 have dyslexia. So it may be mild, it may be severe, but it is very, very prudent to have a history with every parent presenting with a poor school performance. I'm not going to go into the details of this child. So with the reading, it is dyslexia. With the reading, it is dyslexia. Mathematics, calculia. Writing is graphia. Fine motor skills is praxia. Language is phasia. Difficulty hearing differences between the sounds is auditory processing. Interpreting the visual information is visual processing. So this we have heard in our undergraduate and postgraduate days. I'm not going to go
but I'll give you few examples which will be striking for you. A dyslexic child will be having a confusion with the alphabet. He will write instead. Mother will typically say, "Sir, B and D are U ku badala N potra." Early stage, this may be normal. Probably at 3.5 to 4 years or early writing, this may be normal. But if the same child is doing this at 6 to 7 years of age, you should get alerted. So the mirror images, confusion in the words. He will always read on as no, and he will always write was as saw or something like. So reading the problem. So ACT as cat. So he also reads very slowly, word by word, constantly loses place, missing out lines and reading the same line again and again. So what he does is he keeps a finger in the line and keeps it reading line by line, line by line. He will not, he has hesitancy in reading aloud because he is not sure or confident whether what he reading is right or wrong. So hates reading and refuses to read. May try to sound out individual elements of word, but is often unable to synthesize into the correct word. For example, he will say B, E, G, and finally he will say bad. So that is the thing. He is not able to synthesize into the correct word. So this is a classical example of a dyslexia child pronouncing that. He ignores the punctuation, thus often confusing the meaning of the text. For example, bet. He often bet will be for belt. Instead of belt, he says bet. Went will be wet. Played. In some cases, he just adds ed for play. Instead of play, he will say played. Instead of home, it will be substituted as house. Instead of guest, it will be a house guest. So omission, addition, substitution, mispronounces some words, help for help, portion for position, put syllables in the wrong order, like animal and aminal. So these and all are very common, which parents come and bring in their notes. Hospital, hospital. Gopala Krishnan would be as Golappa Krishnan or something like. So these are the various pronunciation. That is the reading problem. The reading problem, how the child is trying to read from the text or the textbook or from the board. So this is the reading problem. Writing disability, abnormal grip. The child will be writing very slow and laborious. Notes are incomplete. Always the parent has to call the other child's parent and get the notes and incomplete it. Poor in remembering certain alphabets, unable to copy from the board. All these are pointers. Shows mirror writing. Write letters in the wrong order. That is, instead of Simon, he will write S-I-O-M-N. Inconsistent errors. Apple will be spelled as apple or apple or something, right? Reverses letter, as I already reading also and writing also, the same problem will be there. Inverting the letters while reading also, now writing also, he will invert and write. Omit some letters. That is, instead of limp, he will write as lip. String, he will write sing. Sometimes he will add some letters also. Instead of went, he will write W-H-E-N-T. Instead of what, he will write W-H-A-N-T. So this is, see, this is the something which he needs to write. The owl was a bird. See how he has written. A dysgraphic child has written. The words has the letters has some. He ignores the punctuation. The poor organization. So my name is George Isaac. I am studying in 8th standard. I am studying. See, we are not able to read because that doesn't have a proper punctuation and so on. So this is a 7-year-old writing ABCD. There are a lot of reversals are there. The P, R, U, W all have reversed, and even the child has written the name as in the reversed way. So this is a 7-year-old, right? So this is a child. I am a boy. I like to play. See, there are no punctuations, and the child has ineligible handwriting. So these are all pointers towards dysgraphia. See, this is again an example. I am getting friends in school, in our growth. So the teacher has given punctuations are poor, limited idea, need to be organized, and spellings mistakes are a lot. And so coming to the third part of the problem, which is a dyscalculia. How will I find out? Because that sometimes the child may not have a reading problem. Sometimes the child may not have a writing problem. Probably the child may have a mathematical problem, which is called as a dyscalculia. Even after 8 to 9 years, the child will be using the fingers for the calculation. Has difficulty with the multiplication tables. Confuses the 4 basic operations, that is plus, minus, into, and division. Has difficulty to understand the statement problems deciding on operation. The concept of calculation understanding is there, but cannot work out on a paper. Works out answer correctly, but makes mistakes while copying. So these are the, so see here, this is the rough column. 544 plus 432. Correctly, the child has written 976. When from there it is copying to the original fair page, the child has reversed the number. So 697. So this is the example of dyscalculia. Reversing the digits. Even we may think we may have this issue, but probably we have crossed those things and now we are in the medical profession. So probably we are not falling into the full definition of dysgraphia, dyscalculia, something like. Reversing the digits instead of 12, 21, 16, 61. Reading the digit wise. 1008, he will not know to read 1008. He will read 1008. Writing the numbers as we say. If the madam says 450, he will write 450. So that is the way. Lack the knowledge of carry over. 24 to plus 7, he will write 511. So this is the dyscalculia problem. Dyspraxia problem. Very poor, that clumsy movements of the handing. So the poor posture, clumsy movements, poor handwriting, difficulty writing at the speed, poor short-term memory, all are components of dyspraxia. Auditory processing or processing disorder. So this is the thing. Auditory processing, ma'am is selling, write pencils. What our guy is writing, he is writing pencils. Ma'am is writing goats, he is writing goats. Ma'am is asking to write juice, he will write JUSE. So this is auditory processing disorder. Visual processing, again, problems in visual processing, reversing letters, skipping words. So processing through the visual, from seeing from the board and writing. Monkey, the ma'am has written monkey. See how our boy has written MON. He has skipped something, or so the processing, the problem is there. But forget these things. Only think about three things. Problem may be with reading, problem may be with writing, problem is maybe with the calculation. If you understand these three examples, you will be very easily picking up these children at the earliest, and you will be able to guide them properly. So areas affected by learning disability, all these areas, even though it is only learning academic skills, the speech language skills may be affected. Personal social development, the child will not go and interact with other children. Behavior, memory, attention, cognitive skills, all can be affected. So as I already told you, the physical causes, rule out those physical causes, nutrition and physical illness. If it is not there, do a basic IQ, because in learning disability, the IQ may be normal or above normal, it will not be below normal. If the child is having a low IQ, then the child is fitting into an intellectual disability child. Check for whether it has got gross developmental delay or a specified developmental delay. If no, check whether the child has got poor motivation. If whether the child has got inattention, because a child with inattention also will not be able to study. If no, look for emotional, conduct and psychological problems. If no, look for specific learning disability. As I already told you, think about only three things: whether he has a problem with reading, whether he has a problem with writing, whether he has a problem with calculation. So this finishes. Finally, coming to the management of the poor performance, refer early for intervention. All neurodevelopmental problems, it is early referral, because the neuroplasticity till 2 years. So after that, whatever efforts you want to do, if you want to make a child study 10th standard, you have to make all the efforts put at 10th standard. You cannot make the child do 10th standard when he is supposed to do the college education. So one child may have more than one cause, look for that cause. So who will diagnose? A proper team who will all do a multidisciplinary, all those assessments and all those scoring has to be done, because this is a very, very important diagnosis. The scoring has to be done by the proper people. An IQ assessment has to be done. All those comorbidities has to be evaluated. So the multidisciplinary team of ophthalmologists, otolaryngologists, ENT, pediatricians, psychologists, psychiatrists, and a special educator, they will be able to guide these children on. I'm not going to the functions or the roles of each of those persons, but all these people will be working on these children, and they will be trying to improve the academic performance of these children. So treat the medical problem if it is there. Correction, hearing and visual impairment if this there, correct. Always continue in the mainstream school or the inclusive education. Try for remedial education if the child has got specific learning disability. So this is the try from a dyslexic. Instead of scolding and blaming me, please teach and assist me. That is very, very important. And beating with a belt is not the solution if the child is learning. Find out why he is not learning and try to correct that problem. And we have a lot of concessions from the various boards, the Tamil Nadu State Board, Samachir Kalvi, ICSE, CBSE. NIOS, they have given many concessions like extra time, overlooking the spelling errors, calculator in the mathematics, having a scribe, exception from second language and everything. So only when you help them make a diagnosis, refer them to the right person who can make a diagnosis. For that, the pediatrician has to spend the time in understanding the problem of the parent. So then only you will be able to find out which child has got a dyslexia or something like. So when you find these children, you will be able to guide them and help them acquire these concessions from the government, so that they will also be benefited. So the point is, if there is a symptom like fever, if there is a fever, you try to find out whether it is typhoid, malaria, urinary infection, or ear infection, or something like, always like that. Poor school performance is a symptom. It is only showing. It's only a symptom. Always find out what is the cause for the poor school performance, rather than writing an IQ medicine or a memory medicine for the child. Find out why this child is poorly performing in the school, whether it is a child factor, whether it is a school factor, or whether it is a family factor. If it is the child factor, which thing it is fitting into. If a child cannot learn the way we teach, maybe we should teach the way he learned. That is very, very important. You have to change the way which the child has learned. So rather than labeling, you have to enable all these children with the poor school performance, and all the dyslexic should become great people. And thank you so much for this opportunity.
Yeah, actually, it's a very super fast talk. Sounds probably 15-20 minutes. You have clubbed so many data into it. But I think you covered almost all the aspects. Like you looked at what are the problem areas in reading, writing, particularly difficulty in tables and reversing letters. I think benefits of early intervention, what has to be done. I think you have covered everything in detail. I think that's a very good talk, Somasundram. Mainly, practically, what I would suggest to general pediatricians is focus on few things, like parental concern is there on education. As Dr. Somasundram told, look at psychosocial factors, biopsychosocial factors, and mainly focus, pay more attention to the concerns. I think one practical thing which I found very useful is, if the mother says, like, I have to repeatedly teach him alphabets and numbers, and he has difficulty in that before and after number concept, even by age of 5 to 6 years, and difficulty telling rhymes clearly, I think better you seek proper referral and evaluation. Because that can do a lot of good for the child. I think these three things only stand out very prominently in our assessments of LD. Like we do around 5 to 6 LD assessments every month. And I think these are the points which we need to look at in our gender practice, and maybe can be the take-home points. And I think any doubts, I think we can focus on it. And another interesting information which I would like to share is, we think that we have to read to the child only when the child is, say, 1.5 years of age. But studies have shown that if you are exposing the child to text at 6 months, the child's reading ability at 3 to 4 years will be much faster than the same age group. So there are a lot of things that is happening in the first 2 to 3 years. That's what some were talking about, early intervention and for critical, the first 2-year period. I think those sort of things, I think we should take out to the public through pediatricians, and that makes a very big difference. The utilization the first 2 years is very, very important. Maybe motor, maybe emotional, maybe social, maybe even language. I think that plays a very big role in the individual's life. And if that is a take-home point, I think it's a very good session. I thank all the audience, because I think still 60% of people are attending after 3.5 hours, I think, of deliberations. I think that shows that the passion is very good, and that speaks highly about the speakers, like say Dr. Somasundram, Dr. Sudhakar, Dr. Lal, Dr. Srinivas Raghavan, Dr. Venkateswaran, and Dr. Rama Chandramohan. I think it's overall very good session. Thank you all.
Thank you very much, sir. As you rightly told, the pediatricians, the 4 P's are very important in taking up this developmental projects to the community, sir. The first P is the primary pediatricians. They should be thoroughly sensitized, and they should update on all the available tools. And because neurodevelopmental problems are fast increasing, so that is the primary pediatrician. The second P is the primary school teacher, and the primary and the preschool teacher. They should be sensitized so that they can pick up the early developmental problem. The third is the parent. most parents deny the diagnosis at the first turn. So they should be sensitized that these problems, if treated early, they can have a better diagnosis. The fourth is the public. The public also has to be sensitized. So if all the 4 P's are very well sensitized in these neurobehavioral problems, lot can be early diagnosed. And as early diagnosis can go a long way in treating these children. Sir, Dr.
We'll take one last question. Yeah. Shall I take it? So,
yes, sir, please.
Yeah, I think if you are using CBCL as a questionnaire, okay, we can pick up as early as, say, beyond 1 to 2 years, we can pick up attention problems. We don't define it as a disorder, because once you say it's a disorder, it's a permanent thing. And it should be impacting the function of the child in 2 separate domains, not only in domestic setting, but also in school setting or maybe in a community setting. So we can't make a diagnosis of ADHD, but we can make a diagnosis of ADHD problem. But when you are making that diagnosis, what we need to be careful is, we need to be very careful about the active toddler. Okay, we'll also be using all those, we'll be showing those symptoms of hyperactivity. So I think it's more a question of not only the child, how the parents are reacting to the child, which boils down to the parenting styles which the parents are adopting. I think that also should be looked at. If you are seeing children below, like say 3 or 4 years, maybe you have to look at the child's problem, how the parents interact with the child and other social issues. And maybe then we have to figure out whether it is a ADHD problem or is it a normal toddler behavior. And you can't make a diagnosis of ADHD before 6 or 7 years. And I thank the organizers also. I think that has answered your question. So I think once you start seeing more of these children, I think our familiarity with this diagnosis will be easier, because our exposure during our MD time is actually in development pertains only to the short notes, 2 short notes which we'll be writing. But it's much bigger field now, and I think if more people are taking it up, it's a very good occasion. Good. Thanks, Soms.
Thank you, sir. Thank you very much, madam. All those speakers and Professor Ramachandra Mogan and Professor Uday Kumar, who have spent nearly 3.5 hours. We have overshoot by 45 minutes. Even then, at the end of the day, we are very happy that it has reached many pediatricians, and it will be helpful to carry out in their practice. Yeah. Another one question: how long can we finish off those?
Yeah, you take Soms.
How long to wait for speech delay? I can say that. So as we discussed, speech delay, we have to know what is the cause for the speech delay. If you are very clear that the child has got a good receptive, the child is good, has got non-verbal communication is very good, the child has got good interaction with the parents, but only the words are yet to come, or the words are only delayed. Instead of saying Amma Paal Venu, the child is just saying Amma, or sometimes it is Paal, and that is also parent oriented or caregiver oriented. Then you can probably wait for 2 years, probably if the child is fitting into a late talker or something like. If it is not like that, if the child's receptive language is itself poor, then it is better early to do a hearing assessment first. And the child is not able to follow your instructions or lead at all, then it's better you do, and at the earliest you do the hearing assessment. Or if you have any suspicion on the child's social interaction or two-way interaction, go for an MChat or an ASD evaluation. Thank you.
Okay, thank you, Dr. Somsundaram.
Yes, the organizers of IAP TNSC.
Yeah, thank you. It's a great pleasure having another lovely CME over here today. I think the A to Z of neurodevelopmental problems have very well been covered. Let me start with thanking our secretary and president for being keenly enthusiastic in organizing these monthly CMAs. I would thank Professor Ramachandra Mogan and Professor Uday Kumar for for moderating these sessions very well. The convener of today's CME, Dr. Somasundaram, I think chose an apt time to do such a very important CME, given that given the COVID lockdown, there are plenty of doubts and a lot of children with learning and developmental behavioral problems. And so I hope most of these doubts are clarified among the participants of our CME. So thank you very much, Dr. Soms. I thank all the speakers of the today's CME. I think they really conveyed their vast experience and simplified a fairly complex topic as simple as possible. So thank you and to all the speakers. And let me conclude by thanking all the delegates of our online CME who have patiently listened to all the lectures and who have contributed to the discussion by clarifying their doubts. So thank you once again. And we should have our next CME will be by the end of this month, and it's most likely on neonatology. So thank you very much and hope to see you again. So thank you and all. Thank you, sir.
Thank you.